So this will be the psychiatry and behavioral health section of Pance Prep Pearls. So first we'll start with abuse and neglect. First, intimate partner abuse. So according to the CDC, 1 in 4 women and 1 in 7 men will experience physical violence by their intimate partner at some point during their lifetimes. About 1 in 3 women and 1 in 6 men experience some form of sexual violence during their lifetimes. A bolded point, a woman who leaves an abusive partner has a 70% greater risk of being killed by the abuser compared to staying. Abuse during pregnancy can make up about 10% of overall pregnancies and pregnancy-related hospital admissions. And barriers to screening include lack of privacy, low self-esteem, fear, sensitive nature of intimate partner violence. So some of the clues of violence are contusions on the breast, chest, abdomen, face, musculoskeletal injuries, and accidental, quote-unquote, injuries. They have multiple injuries in various stages of healing, importantly, not just one. And also patients may have non-specific general symptoms like fatigue and headache. So management of intimate partner abuse, if it's encountered, all healthcare facilities should have a plan that includes screening, assessing, and referring patients for intimate partner violence. Once it is suspected, patients should be addressed directly with a non-threatening question to confirm if the intimate partner abuse has occurred. If it has occurred, then alternatives should be discussed with referral if the patient accepts it as the patient's right to accept or refuse help. Next, to sexual abuse. So according to the National Sexual Violence Resource Center, more than 1/4 to 1/3 of female children have experienced sexual abuse before 18 years of age. Common ages of sexual abuse are between 9 and 12 years old. And perpetrators, this is a bolded point, perpetrators are most commonly males, and most are actually relatives to the child or known by the child or have access to the child. 33% of sexual offenders were once themselves victims of sexual abuse, and any of the following should increase the risk of suspicion of child abuse, like children that exhibit sexual knowledge, initiate sex acts with peers, show knowledge of sexual acts, bruises, pain, or pruritus in the genital area or anal area, or evidence of STDs. For physical abuse, abusers are often female and usually the primary caregiver. Signs include cigarette burns, burns in a stocking glove pattern, lacerations, healed fractures and radiographs, subdural hematomas, multiple bruises, or retinal hemorrhages. Hyphema or retinal hemorrhages are seen with shaken baby syndrome. For child neglect, failure to provide all the basic needs of a child like supervision, food, shelter, affection, education, etc. Some of these signs include malnutrition, withdrawal, poor hygiene, and failure to thrive. So next we'll go to anxiety disorders. First in anxiety disorders will be panic attacks. So of panic attacks, these are sudden, abrupt, discrete episodes of intense fear or discomfort that usually peaks within 10 minutes and rarely last for more than an hour. Most end in 20 to 30 minutes. Patients feel very anxious for hours after the attack, however. Clinical manifestations. So you need at least 4 of the following symptoms of sympathetic system override to diagnose it. You also have a sense of impending doom or dread. So in the category of sympathetic overdrive seen in panic attacks, we have dizziness, trembling, a choking feeling, paresthesias, sweating, shortness of breath, chest pain, discomfort, chills or hot flashes, fear of losing control, fear of dying, palpitations and increased heart rate, nausea and abdominal distress, and also depersonalization, feelings of being detached from oneself, or derealization, feelings of unreality. So how do we manage these acute attacks? Benzos are the first line management like alprazolam, lorazepam, diazepam, etc. But you want to watch for dependence or abuse. So with a panic attack, even in patients with panic disorder, one must actually rule out potentially life-threatening conditions, especially like a heart attack or thyrotoxicosis, for instance. Panic attacks are the feature of many different anxiety disorders, but it's not a disorder in and of itself. And for panic attacks, you want to get a BMP, TSH, and also EKG. For panic disorder, the average onset is in the early to mid-20s, and there is a greater risk if a first-degree relative is also affected. And over 60% may also develop depression, and it's more common in females overall, panic disorder. The diagnostic criteria for panic disorder is recurrent, unexpected panic attacks, at least 2 previous attacks, so recurrent and unexpected. They may or may not be related to a trigger, and at least one of the following must occur for at least 1 month. So panic attacks often followed by persistent concern about future attacks, persistent worry about the implication of attacks, like losing control in a situation, or 3, significant maladaptive behavior related to the attacks. So the symptoms of a panic attack or panic disorder are not due to substance use or abuse, or medical conditions like thyroid, hypoglycemia, which can mimic sympathetic, or cardiac, or other mental disorder as well. And it's important to mention agoraphobia here in the diagnostic criteria for panic disorder. Agoraphobia is anxiety about being in places or situations from which escape may be difficult, like open spaces, enclosed spaces, also crowds, public transportation, or outside of the home. Agoraphobia is now seen as a separate entity, however, from panic disorder, and can occur with other psychiatric disorders. So management of long-term panic disorder is SSRIs as the first-line medical management. Examples are sertraline, citalopram, fluoxetine, and you can initiate an SSRI plus a benzo, and then taper and discontinue the benzo if needed. SNRIs are also used, like venlafaxine, and TCAs are last line after that if SSRIs, SNRIs are ineffective. You should also do CBT, cognitive behavioral therapy. It's adjunctive treatment that focuses on thinking and behavior, like relaxation, desensitization, examining behavioral consequences, and psychotherapy may be used in mild cases as initial therapy. Pharmacotherapy and CBT are most effective. So you want to do the both of them if you can. So you want to do the pharmacotherapy with the SSRI and CBT if you can. For acute panic attacks, like we said, benzos, alprazolam, and clonazepam. But you also want to know who you're giving these to and if there's a risk for dependence. So next will be agoraphobia. Agoraphobia is an intense fear or anxiety about being places or situations from which escape or obtaining help may be difficult. Like we said, open spaces such as bridges, enclosed spaces or crowds, public transportation, or being outside of the home alone. Although it is commonly seen with panic disorder, agoraphobia is now once again a separate entity from panic disorder and can occur with other psychiatric disorders. The triggering situation causes anxiety and fear out of proportion to the potential danger of the situation, and bolded here, symptoms last for at least 6 months. To diagnose agoraphobia, it has to be at least 6 months, causing significant social or occupational dysfunction, and it's not better explained by another disorder, including mental disorders. So at least 6 months for agoraphobia. Management, CBT, and SSRIs have the best outcome. Next will be generalized anxiety disorder. Generalized anxiety disorder is most common in females. The onset is usually early 20s. Diagnostic criteria of generalized anxiety disorder is an excessive anxiety or worry a majority of the days for at least 6 months about a variety of aspects of life. The anxiety is usually out of proportion to the event. It must be associated with at least 3 of the following: fatigue, restlessness, difficulty concentrating, muscle tension, sleep disturbance, irritability, shakiness, and headaches, but especially fatigue. It's not episodic like panic disorders are, and it's not situational like phobias are. And the symptoms are not due to medical illness or substance abuse, but they do cause significant social and occupational dysfunction. So remember, agoraphobia and generalized anxiety disorder over 6 months. Generalized anxiety disorder, variety of aspects of life. For management, antidepressants, SSRIs are first line, fluoxetine, paroxetine, escitalopram, again, SNRIs as well. And importantly, buspirone can be used adjunctively to SSRIs. It does not cause sedation. And again, CBT plus psychotherapy and psychotherapy plus pharmacology are the most effective, then either used alone. And benzos can actually be used for short-term use only until long-term therapy takes effect. Beta blockers or TCAs can also be used. So for buspirone itself, the mechanism is a partial serotonin, 5-HT1A, receptor agonist and dopamine antagonist. So increases serotonin, decreases dopamine for buspirone. And buspirone is typically used in generalized anxiety disorder, and it does not cause sedation and does not potentiate the CNS depression effect of alcohol, almost negligible abuse and addiction potential. It takes 1 to 2 weeks to take full effect. For social anxiety disorder, formerly social phobia, this is the most common type of phobia, such as in public speaking. The diagnostic criteria for social anxiety disorder is disabling, persistent, at least 6 months again, intense fear of social or performance situations in which the person is exposed to the scrutiny of others, and especially for the fear of embarrassment, like public speaking, meeting new people, eating or drinking in front of them, or using public restrooms. Exposure to social situations almost always provokes anxiety and causes expected panic attacks. These are expected panic attacks for over 6 months. They may realize feelings are excessive and out of proportion to any actual threat or danger, and they may avoid those situations specifically. The management is psychotherapy, which is the initial treatment of choice, CBT, desensitization, relaxation, insight-oriented therapy as well. And psychotherapy is that first line, and then you do SSRIs, like fluoxetine, sertraline, etc. SNRIs, second line. Adjunctively, benzos. Most patients in moderate to severe cases benefit from a combo of pharmacotherapy and psychotherapy, and for situational social anxiety disorder, beta blockers are used for performance anxiety and in public speaking, like propranolol and atenolol, 30 to 60 minutes prior to the performance. So next, for specific phobias, the diagnostic criteria for a specific phobia is persistent, again at least 6 months, intense fear or anxiety of a public situation, or a specific situation like heights and flying as well. Also objects like pigeons, snakes, or blood, or places like hospitals. The exposure to the trigger of the situation requires an immediate response, and the fear is out of proportion to any real danger. The phobic object or situation is actively avoided or endured with intense fear or anxiety. Bolded, everyday activities must be impaired by the distress or avoidance of the object or situation, and it's not due again to substance use or medical condition. Some of these subtypes are animals like spiders, dogs, and mice, situational like airplanes and elevators, or natural environment like heights, thunder, and water. Also blood injection injury like injuries, needle injections, or blood. For management, exposure and desensitization therapy are the treatment of choice. Short-term benzos or beta blockers can be used in some patients as well. Next, we'll go from anxiety disorders to mood or affective disorders. First in mood and affective disorders are major depressive disorder, MDD, and unipolar depression. The risk factors for depression are a family history and also female to male ratio of 2 to 1, so more common in females. The peak onset of age is in the 20s. The pathophys of depression is an alteration in neurotransmitters, serotonin, epinephrine, norepinephrine, dopamine, acetylcholine, and histamine, also other genetic factors. Other pathophys are neuroendocrine dysregulation, adrenal, thyroid, or growth hormone dysregulation. 15% of patients commit suicide with major depression, especially in men 25 to 30 and in women 40 to 50. Higher suicide rates in patients with a detailed suicide plan. Also white males over 45 and concurrent substance abuse. The PHQ-2 is the initial screen, the patient health questionnaire 2. And if it is positive, then you want to move on to the PHQ-9. For diagnosis, you want to use your DICE's GAPS, and this is 5 out of 9 for 2 weeks. So for diagnosis of major depressive disorder, at least 2 distinct episodes of at least 5 associated symptoms must either include depressive, mood, or anhedonia, almost every day for most of the days for at least 2 weeks. Importantly, at least 2 weeks. A depressive mood, anhedonia, fatigue almost all day, insomnia or hypersomnia, feelings of guilt or worthlessness, recurrent thoughts of death or suicide, psychomotor, agitation or retardation, restlessness or slowness, significant weight change, gain or loss, decreased or increased appetite, and decreased concentration or indecisiveness. It's not associated with mania or hypomania. These symptoms must cause significant distress or impairment, social, or occupational impairment. And the symptoms, of course, are not due to substance use, bereavement, importantly, or medical conditions. So they give you a situation where the patient's having bereavement, and they say, is this major depressive disorder? And the answer is no, because they're having bereavement. So management of major depressive disorder, psychotherapy, of course, CBT, interpersonal therapy, and supportive therapy. SSRIs are the first-line medical management, and you want to give them at least 4 weeks to start working. And if there's no effect in 4 weeks of SSRIs, switch to another SSRI. Second line, SNRIs like duloxetine, venlafaxine, and also bupropion. TCAs and Tetracyclics and MAO inhibitors can also be used. And electroconvulsive therapy. Electroconvulsive therapy is a rapid response in patients unresponsive to medical therapy and unable to tolerate any other pharmacotherapy, such as if they're pregnant, or having a rapid reduction of symptoms. So there are some subtypes or classically course specifiers of major depressive disorder. 1. Seasonal affective disorder or seasonal pattern. This is the presence of depressive symptoms at the same time each year, most commonly in the winter, quote-unquote winter blues, due to the reduction of sunlight and cold weather. The management is the same, except adding light therapy, so SSRIs and light therapy for seasonal affective disorder. There's also atypical depression. Atypical depression shares many of the typical symptoms of major depression, but patients experience mood reactivity. Mood reactivity. This is improved mood in response to positive events, so they're depressed until something positive actually happens. Symptoms include significant weight gain or appetite increase, hypersomnia, heavy or a leaden feeling in the arms or legs, and oversensitivity to interpersonal rejection. Management is MAO inhibitors, interestingly. Melancholia. Melancholia is characterized by anhedonia, inability to find pleasure in anything, lack of mood reactivity, depression, severe weight loss, loss of appetite, excessive guilt, psychomotor agitation or retardation, and sleep disturbance, increase in REM sleep, and reduced sleep overall. Sleep disturbances may lead to early morning awakenings or mood that is worse in the morning. And lastly, there's also catatonic depression. Catatonic depression is a motor immobility, stupor, and extreme withdrawal. So that's catatonic depression, where they don't move. So to go over the overall management here, SSRIs, we'll start with SSRIs, selective serotonin reuptake inhibitors. These drugs are citalopram, escitalopram, paroxetine, fluoxetine, sertraline, and fluvoxamine. The mechanism is selectively inhibit CNS uptake of serotonin, leading to an increased serotonin activity in the CNS. They're indicated as first line for depression, PTSD, panic disorder, premenstrual dysphoric disorder, and anxiety disorder in most cases. They're very effective, and they're relatively mild in their adverse effects, and they're less toxic in overdose compared to other antidepressants. This is because they don't affect norepinephrine, acetylcholine, histamine, or dopamine. They're only selectively inhibiting the reuptake of serotonin. So fluoxetine. Fluoxetine is important to note as it's the only antidepressant approved for the treatment of bulimia. So bulimia, fluoxetine, FLU. Fluoxetine has a long half-life, 2 to 4 days, so that's why it's good in bulimia, which is comparing to the other SSRIs about only 1 day. And again, because of its longer half-life, there's a longer washout period for switching to an MAOI, 5 weeks, compared to other SSRIs, at least 2 weeks. So if they have to switch, and they're on fluoxetine, you need to know that it's going to take much longer before they can switch to a different drug. So on average, antidepressants take 4 to 6 weeks to reach maximum efficacy. If there is no response, switch to another SSRI. Don't switch to a different class of drugs. So you want to try another SSRI. Adverse effects of SSRIs: GI, nausea and diarrhea, also headaches, changes in energy level, sexual dysfunction, very importantly, sexual dysfunction, decreased libido, anorgasmia, anxiety, insomnia, weight changes, SIADH, and serotonin syndrome is a risk. Increased suicidality in children and young adults, so anybody under 24 years old has an increased risk of suicidality. Avoid citalopram in patients with a long QT syndrome. So long QT syndrome, weight changes, sexual dysfunction, and GI, and also insomnia. SNRIs will be next, serotonin and norepinephrine reuptake inhibitors. This is duloxetine and venlafaxine. The mechanism to inhibit neuronal reuptake of serotonin, norepi, and some dopamine as well, mostly serotonin and norepi. Duloxetine may be used as first-line agent, particularly in patients with significant fatigue or neuropathic pain syndromes and associated with depression. Venlafaxine is good for depression and anxiety disorder. So remember, duloxetine, very importantly, also helps neuropathic pain syndromes. Adverse effects, safety, tolerability, and adverse effect profile similar to SSRIs, including hyponatremia, but it also has the effects of norepinephrine, like hypertension. So it's increased sympathetic activation, so you're going to have some hypertension as well, sweating, dizziness, dry mouth, constipation. And it's contraindicated to use an SNRI if MAOIs are being used, or if they have renal or hepatic impairment or seizures. And of course, avoid abrupt discontinuation, and use in cautions with patients with hypertension. And what else increases the risk of serotonin syndrome, SNRIs, and also St. John's wort, which is a herbal medication that can be used over the counter and also increases serotonin. Next, tetracyclics, not tricyclics or tetracyclines, but tetracyclics. This is mirtazapine. So mirtazapine, the mechanism of action is to increase the release of norepinephrine and serotonin via central presynaptic alpha-2 adrenergic receptor antagonism. It has a high affinity for histamine H1 receptors, leading to its sedative properties. But postsynaptic serotonin 5-HT2 and 5-HT3 receptor antagonism also takes place, which increases neurotransmission mediated by the serotonin 5-HT1 receptors. So indications of tetracyclics, which is mirtazapine, are depression and anxiety disorders. It has anxiolytic properties as well, and it can be used with trazodone. So it's used for depression as well, especially patients with insomnia or significant weight loss. It has an appetite stimulating and sedating property. It also has fewer sexual side effects compared to other SSRIs. So, importantly to know about mirtazapine overall, helps also in anxiety disorders, can be used with trazodone, but very importantly, fewer sexual adverse effects to SSRIs, and also increases your weight because it stimulates, or it should be used in patients with significant weight loss because it stimulates appetite, and it helps patients sleep as well, kind of like trazodone does. Adverse effects are sedation and weight gain, again, appetite stimulant, also some dry mouth, constipation, tremor, dizziness, agranulocytosis. And of course, never used with an MAOI and may cause serotonin syndrome. Tricyclic antidepressants, TCAs, are next. So TCAs are tertiary treatment. They're amitriptyline, clomipramine, imipramide, and doxepine. Secondary are diazepamine and nortriptyline. The mechanism are inhibiting the reuptake of serotonin and norepinephrine, and they're indicated in depression, insomnia, also neuropathies just like duloxetine, diabetic neuropathic pain, postherpetic neuralgia as well, migraine, and urge incontinence. They're used less often because of their adverse effect profile and severe toxicity with overdose. So their adverse effects, to go through them, are anticholinergic effects, which are most common. Very importantly, dry mouth, constipation, urinary retention, tachycardia, and orthostatic hypotension. The elderly may experience confusion and hallucinations. So remember, this can be a cause for delirium in the elderly as well. Other side effects besides the anticholinergic are also weight gain and prolonged QT interval, which is the best indicator of an overdose. So you should be very cautious of the prolonged QT interval in a overdose. Sedation, antihistaminic effects, like kind of like Benadryl makes you sleep, also sedation here with the TCAs due to its anticholinergic and antihistaminic effects, also lowering the seizure threshold and SIADH. If they have an overdose, they have the 3 C's: cardiotoxicity, a wide complex tachycardia due to the sodium channel blocking effects, convulsions, seizures as it lowers the seizure threshold, and other neurologic symptoms like respiratory depression and coma. So coma, cardiotoxicity, and convulsions. And the management is sodium bicarb, can be used for the cardiotoxicity. Contraindications and cautions: use of MAOI inhibitors, recent MI, and seizure activity. So to go over the different TCAs and some specific facts about them that are commonly tested. So these are, so there's tertiary amines and secondary amines, like we said. So for the tertiary amines, these are the most anticholinergic, the most antihistaminic, sedating, and the most antiadrenergic, so the higher toxicity with overdose. This is amitriptyline. Amitriptyline is commonly used in headache, and it's also used in neuropathies and chronic pain due to the sodium channel blocking properties and insomnia. That's for amitriptyline. For clomipramine, it's used in OCD, obsessive compulsive disorder. It's the most serotonin specific. So I remember clomipramine has O and C in it, so I remember OCD. Doxepine is used for chronic pain. Imipramine is used for enuresis in children and panic disorder. So it's used for incontinence. So imipramine, I think incontinence, IM, very similar. So imipramine is for incontinence. There's also secondary amines. They're less anticholinergic, antiadrenergic, and antihistaminic, so they're less sedating overall. This is dazipramine, which is the least sedating, the least antihistaminic, and the least anticholinergic, and also nortriptyline. It's the best tolerated, and it's the least likely to cause orthostatic hypotension. So I think orthostatic hypotension being the least N, which is like no or none, and then OR, so orthostatic. So for some exam tips here below, we have in general, the SSRIs are first-line medical therapy in most cases because they are effective, have a relatively mild adverse effect, and less toxicity in overdose compared to other antidepressants, especially TCAs. On average, antidepressants take about 4 to 6 weeks to reach the maximum efficacy. In patients not responsive to initial SSRI therapy after 4 to 6 weeks, switch to another SSRI. And duloxetine is the first line of depression and neuropathic pain. Bupropion may be preferred if patient is fearful of sexual dysfunction or weight gain. It's also good for smoking cessation. So next we will go into bupropion, which is an NDRI, a norepinephrine dopamine reuptake inhibitor. So mechanism is inhibiting the neuronal presynaptic uptake of dopamine and norepi. Bupropion is indicated in depressive disorder and seasonal affective disorder. It's marketed as Wellbutrin. It has less GI, less weight gain, and sexual adverse effects compared to SSRIs. It's useful in depressed patients who are fearful of sexual side effects or weight gain. It also aids in smoking cessation. It's marketed as Zyban, and it's useful in depressed smokers trying to quit. Adverse effects: seizures, it lowers the seizure threshold, dry mouth, nausea, insomnia, agitation, anxiety, weight loss, hypertension, headache, increased risk of psychosis at higher doses, and avoid abrupt withdrawal, of course. It has a few important contraindications with bupropion, especially epilepsy or conditions with increased seizure activity, like eating disorders, such as bulimia and anorexia, or patients undergoing abrupt discontinuation of alcohol, benzos, barbiturates, or antiepileptic medications. So remember, the electrolyte levels are changing a lot, especially in eating disorders like bulimia and anorexia. So avoid in patients with MAOI use in the past 2 weeks as well. So then we'll go to non-selective MAOI inhibitors, or monoamine oxidase inhibitors. This is phenelzine, transilpramine, and isocarboxazid. The mechanism of action is blocks the breakdown of neurotransmitters, increasing the levels of norepi, serotonin, dopamine, epinephrine, and tyramine by inhibiting monoamine oxidase. It's indicated in refractory depression or refractory anxiety disorders. The adverse effects of MAOIs are orthostatic hypotension is the most common, also insomnia, anxiety, weight gain, sexual dysfunction, and also hypertensive crisis after ingesting foods higher in tyramine, such as aged or fermented cheese, or smoked, pickled, or cured meats, poultry, fish, red wine, drafted beer, and chocolates. It also, MAOs inhibit prevent the breakdown of tyramine, leading to hypertension. So tyramine is in the steps of hypertension, so you want to be worried about tyramine from these foods and getting hypertensive crisis from that if on an MAOI. Some drug interactions are increased risk of serotonin syndrome if MAOIs are combined with SSRIs, SNRIs, or St. John's wort. MDMA, cocaine, meperidine, tramadol, and dextromethorphan. Wait at least 2 weeks before switching to MAOI inhibitors to SSRIs or vice versa, 5 weeks for fluoxetine due to its longer half-life, remember used in bulimia. And MAOIs and TCAs may cause delirium and hypertension. So especially hypertension, remember that hypertensive crisis with the tyramine for MAOIs. And the next one we'll go to serotonin receptor antagonists and agonists. So this is trazodone or nefazodone. The mechanism of trazodone is a serotonin antagonist and agonist. So it's postsynaptic serotonin 5-HT2A and 5-HT2C receptor inhibitor. It weakly inhibits presynaptic serotonin uptake. It's a reuptake inhibitor. Its active metabolite is a serotonin receptor agonist. Alpha-1 adrenergic receptor antagonist as well, which leads to its sedative properties. It's indicated as an antidepressant with anxiolytic and hypnotic effects, as it's useful for insomnia. So trazodone is prescribed a lot for insomnia. May be used as a sleep aid, especially in low doses. Unlike SSRIs, trazodone does not affect the REM sleep or cause any sexual adverse effects. Adverse effects are sedation, most common, dizziness, dry mouth, nausea, orthostatic hypotension, and headache. Also, priapism is a rare but a classic adverse effect. So priapism and sedation for trazodone. It also increased suicidality in young children and adults and cardiac arrhythmias. Nefazodone has a black box warning for rare but serious fulminant hepatitis. Most importantly though, trazodone, sedation, and priapism. Next we'll go into serotonin syndrome. Serotonin syndrome is a potentially life-threatening syndrome due to the increased serotonergic activity in the CNS. The etiologies most commonly occur within 24 hours, especially 6 hours, with initiation or change in a serotonergic drug, such as SSRIs, SNRIs, TCAs, MAOIs, buspirone, triptans, or a combination of these medications with St. John's wort, MDMA, cocaine, or amphetamines. On physical exam for serotonin syndrome, you may see cognitive effects like altered mental status, confusion, agitation, hallucinations, hypomania. Also autonomic instability like hyperthermia, tachycardia, diaphoresis, and blood pressure changes. GI serotonergic effects like nausea and vomiting, increased bowel sounds and diarrhea, and neuromuscular hyperactivity like spontaneous or inducible clonus, hypertonia, increased DTRs, tremor, akathisias, which is restlessness, akathisia. You'll have mydriasis, dilated pupils, dry mucous membranes, and flushed skin. So for diagnosis of serotonin syndrome, it's clinical, but you can also use the Hunter criteria. In the management of mild serotonin syndrome, you want to do prompt discontinuation of the offending drug, which is most important, and also supportive care is the mainstay. Supplemental O2, IV fluids, benzos for the agitation, importantly. Also to reduce hyperthermia and correct mild increases in heart rate and BP. So the management of moderate, you do the above, so that's the benzo and the supportive care, plus cyproheptadine. This is a serotonergic antagonist. Antipyretics should not be used for hyperthermia. So serotonin syndrome treatment, cyproheptadine, as well as a benzo, and do not use antipyretics. Next will be bipolar disorder. The risk factors for bipolar disorder are a family history first and foremost, and most importantly, a family history of a first-degree relative with bipolar disorder is the strongest risk factor. They're 10 times more likely. And also men are equal to women in bipolar 1 disorder. 1% of the population are bipolar, and the average age of onset is 20s to 30s. A new onset is rare after 50 years old. The earlier the onset, the greater the likelihood of psychotic features, and also the poorer the prognosis. So the diagnostic criteria of bipolar 1 in differentiating from bipolar 2 is very important. So for bipolar 1, at least one manic or mixed episode must be had. This is the only requirement. The manic episodes often cycle with occasional depressive episodes, but major depression episodes are not required for the diagnosis. So what is mania? Mania is an abnormal and persistently elevated, expansive, or irritable mood for at least 1 week, or less if hospitalization is required. And this also has marked impairment of social and occupational function, at least 3 different things: mood, with euphoria, irritability, labile or dysphoric mood; thinking, racing flight of ideas, disorganized, easily distracted, expansive or grandiose thoughts, like a highly inflated self-esteem; judgment is impaired, such as spending sprees; and also behavior, physical hyperactivity, pressured speech, decreased need for sleep, may go days without sleep; also increased impulsivity, excessive involvement in pleasurable activities, including risk-taking, hypersexuality, disinhibition, and increased goal-directed activity. They may also have psychotic symptoms, paranoia, delusions, hallucinations, which may be seen. Symptoms are not related to any other medical condition or substance use. So the management of bipolar 1, mood stabilizers are first line, lithium; acute mania and long-term management. Lithium also decreases suicide risk. Valproic acid or carbamazepine are useful for rapid cycling or mixed features. And second-generation atypical antipsychotics can also be used. Risperidone, quetiapine, olanzapine, ziprasidone are effective as monotherapy or as adjunctive therapy to mood stabilizers. Combination of mood stabilizers and antipsychotics is faster and more effective than monotherapy. Psychotherapy can also be used. This is cognitive behavioral therapy. Also interpersonal and good sleep hygiene is recommended. For bipolar depression, lithium, quetiapine, lorazepam, and lamotrigine can be used. Antidepressant therapy may be used in adjunct to mood stabilizers for severe depression, but antidepressant monotherapy may precipitate mania or hypomania. So we never want to use an antidepressant alone, like SSRI or SNRI, or anything that increases serotonin in these bipolar patients. So you definitely want to have the mood stabilizer, but if they have concordant depression, you can add on that antidepressant. For acute mania, antipsychotics like risperidone or olanzapine are more commonly used over haloperidol, so the second generations over the first generations. You can also do the mood stabilizer like lithium, valproic acid are most effective. Antipsychotics or benzos can be used for acute psychosis or agitation, and electroconvulsive therapy is especially helpful for refractory or life-threatening acute mania or depression. Also is the best treatment for pregnant women with manic episodes. So in ROSH, interestingly, they say first line is a second-generation antipsychotic like risperidone, quetiapine, olanzapine, or ziprasidone. However, here they say lithium is the first line. But here they also say for acute mania, antipsychotics are first line. So I've been going with acute mania, antipsychotics, or overall management, lithium. So we'll go over the difference between bipolar 1, bipolar 2, cyclothymia, and also major depressive disorder, and persistent depressive disorder, which is called dysthymia. So for bipolar 1, they can have a mania or a mixed episode, and major depression is typical in bipolar 1, but it's not required for the diagnosis. In bipolar 2, they can only have a hypomanic episode, no hypermania or mania, and they can have a major depression episode as well, and major depression is typically characteristic of bipolar 2. Cyclothymia, no, they won't have a mania or mixed, but they may have periods of mood elevation, and they may not have, or they don't have major depression. It's associated with a relatively mild depressive episode. Major depressive disorder, no mania, and yes, depression. And persistent depressive disorder, no mania, and usually a mild depression, which can meet the criteria in some cases. So now we'll go over lithium. So lithium's mechanism of action is actually unknown, but thought to alter neuronal sodium transport and influence the reuptake of serotonin and norepinephrine. It's indicated for bipolar disorder, both manic and depressive episodes, also acute mania, a mood stabilizer, schizoaffective disorder as well. There's a lot of adverse effects to lithium, first being endocrine, so hypothyroidism, nephrogenic DI, hyperparathyroidism, hypercalcemia, hypermagnesemia, and sodium depletion. Also increased thirst, and they should drink 8 to 10 glasses of water daily. They also may have neurologic symptoms like seizures, tremor, headache, sedation, GI, nausea, vomiting, diarrhea, weight gain, and for arrhythmias, and also leukocytosis. It's also a very narrow therapeutic index. So prior to taking lithium, You need a basic EKG, chemistries, thyroid function, beta HCG, and CBC should be performed. Initially, the levels should be checked every 5 days and then every 2 to 3 days until it's therapeutic. So once lithium is therapeutic, you want to monitor the plasma levels every 4 to 8 weeks. The levels may be toxic if over 1.5. So how I remember that is TECK, T-E-C-K. So a TSH, an EKG, a CBC, and an HCG prior to starting therapy. And again, quickly for the endocrine adverse effects, as they're important and bolded: hypothyroidism, nephrogenic DI, hyperparathyroidism, which leads to that hypercalcemia, hypermagnesemia, and sodium depletion. So for contraindications, pregnancy, which may be associated with Epstein's anomaly, which is very important, Epstein's anomaly in pregnancy with lithium. Cautions with NSAIDs, thiazide diuretics because of those electrolyte changes, and also ACE inhibitors. Also, what you want to know, impaired renal function is associated with increased lithium levels. Next, for bipolar II disorder. Bipolar II disorder is recurrent major depressive episodes with hypomania. So they never have a manic episode, only hypomania. The diagnosis criteria for bipolar II is a history of at least one major depressive episode and at least one hypomanic episode. Any current or prior manic episode makes the diagnosis bipolar I. So one depressive and one hypomanic. So hypomania is defined as abnormal and persistently elevated, expansive or irritable mood. However, it's under 1 week, whereas mania is over 1 week. So hypomania under 1 week does not require hospitalization, and it's not associated with a marked impairment of social or occupational function, and not associated with psychotic features. At least 3 symptoms affecting mood, thinking, or behavior are present, and the symptoms are otherwise similar to manic symptoms overall. The management of bipolar I and bipolar II are the same, where you use mood stabilizers. Lithium is the first line. Also decreases suicide risk, or second-generation atypical antipsychotics, again like risperidone, quetiapine, olanzapine, ziprasidone. You can also use, if refractory, valproic acid or carbamazepine used for rapid cycling, and psychotherapy is also helpful, CBT, interpersonal, and good sleep hygiene. Moving to persistent depressive disorder, which is also called dysthymia. This is a DSM-5 combined dysthymia and chronic major depressive disorder into PDD, persistent depressive disorder. It's more common in women. Onset is often in childhood, adolescence, or early adulthood. The diagnostic criteria is similar to major depression, except it's chronically depressed mood for at least 2 years in adults, at least 1 year in children and adolescents, that lasts most of the day, more days than not. In that 2-year period, the patient is not symptom-free for at least over 2 months at a time. At least 2 of the following conditions must be present: insomnia or hypersomnia, fatigue, low self-esteem, decreased appetite or overeating, hopelessness, poor concentration, or indecisiveness. They may have a major depressive episode or meet the criteria for major depressive disorder continuously as well. And they must never have a manic episode, so it rules out bipolar I, or a hypomanic episode, rules out psychothymic disorder because of the long duration. For management is a combination of psychotherapy and pharmacology, which is more efficacious than either alone, so you want to do both. SSRIs, SNRIs, TCAs, MAOIs. Psychotherapy, including interpersonal, cognitive, insight-oriented psychotherapies. So, just to reiterate one more time, for a persistent depressive disorder, the diagnosis is a chronically depressed mood for at least 2 years in adults, and they're never symptom-free for greater than 2 months out of these 2 years. For psychothymic disorder, this is similar to bipolar II, but it's less severe. So approximately 1/3 will eventually develop bipolar disorder, and again, men equal to women here, may coexist with a borderline personality disorder, psychothymic. So again, the diagnosis for psychothymic is 2 years of prolonged, mildly elevated, and mildly depressed in mood that do not meet the criteria for a full hypomanic episode or a major depressive episode, at least 1 year in children. So again, at least 2 years, milder elevations and milder depressions than in mood that do not meet the criteria for full hypomanic episodes. Again, the symptom-free periods do not last longer than 2 months at a time in those 2 years. and major depressive, manic, or mixed episodes do not occur. The management is similar to bipolar disorder with mood stabilizers, lithium, valproate, or second-gen antipsychotics, risperidone, olanzapine, quetiapine, ziprasidone. Next will be premenstrual dysphoric disorder, PMS, cluster of physical, behavioral, and mood changes with cyclical occurrence during the luteal phase of the menstrual cycle. Premenstrual dysphoric disorder is severe PMS with functional impairments where anger, irritability, and internal tension are prominent. This is the DSM-5 diagnostic criteria. Clinical manifestations: physical, emotional, and behavioral. For physical manifestations, you have abdominal bloating and fatigue, breast swelling and pain, weight gain, headache, changes in bowel habits, muscle or joint pain. For emotional, you have extreme irritability as the most common symptom. Also tension, depression, anxiety, hostility, and aggressiveness. For behavioral, you have food cravings, poor concentration, noise sensitivity, and loss of motor senses. For the diagnosis of premenstrual dysphoric disorder or PMS, symptoms occurring 1 to 2 weeks before menses, the luteal phase, relieved within 2 to 3 days of the onset of menses. So they're relieved right after the onset of menses within 2 to 3 days, plus at least 7 symptom-free days during the follicular phase. So it cannot be continuously through the cycle. It has to be 1 to 2 weeks before, relieved within 2 to 3 days, and at least 7 days symptom-free during the follicular phase. Also, it's recommended that patients should record a diary of symptoms for over 2 cycles. Management is lifestyle modifications, stress reduction, and exercise is the most beneficial. Caffeine, alcohol, cigarettes, and salt reduction, NSAIDs, vitamin B6 and E. You can also use SSRIs as the first-line medical therapy for the emotional symptoms with the dysfunction, like fluoxetine, sertraline, and citalopram. Oral contraceptive, especially drospirenone-containing OCPs, can be used in patients who do not want to take SSRIs. And gonadotropin-releasing hormone, GnRH, agonist therapy with an estrogen-progesterone add-back if no response to SSRIs or OCPs. So how I remember all the treatment is LSOG, L-S-O-G. So lifestyle, SSRIs, OCPs with drospirenone-containing, and G, gonadotropin-releasing hormones. So next we'll go into suicide. Suicide has many risk factors. So plan is the biggest risk factor. So a previous attempt is the strongest single predictive factor, as 70% of people who commit suicide succeed on their first try. And an organized plan is greater than no organized plans for risk factors. Also, access to firearms is an increased risk. And gender. Females attempt suicide more than men, but men are more successful at committing suicide. For age of suicide, it increases with age, and elderly white men actually have the highest risk in the US. For races, it's whites greater than blacks. And psychiatric disorder, majority who attempt or commit suicide have underlying psychiatric disorders. Substance abuse is increased risk. Marital status alone is a greater risk than never being married, which is a greater risk than being widowed, which is a greater risk than being separated or divorced, which is a greater risk than being married without children, which is a greater risk than being married with children, as marriage is a protective factor in suicide. Others, a positive family history of suicide, history of impulsivity, also chronic illness. Among highly skilled workers, physicians are at an increased risk of suicide. You can remember the suicide as sad persons as the mnemonic. Assuring the patient's safety to prevent the patient from committing suicide is the management, and admission for psychiatric evaluation as well. And once the safety is established, treatment is aimed at diagnosing and treating any underlying medical or mental disorder, including psychotherapy. Next will be conduct disorders. So conduct disorders, this is the persistent pattern of behaviors that deviate sharply from the age-related appropriate norms and violates the rights of others and animals. So conduct disorder, violating the rights of others and animals. These individuals engage in physical or sexual violence, lack of empathy for their victims, and may lack remorse for committing crimes. It's more common in males, higher incidence in ADHD, and with those who've had oppositional defiant disorder, ODD. May progress to antisocial personality disorder as well. The diagnostic criteria for conduct disorders is persistent pattern of violation of the rights of others or age-appropriate societal norms with at least 3 behaviors over the last year and at least 1 incidence within the last 6 months. So they could have had, now these are all important, aggressiveness to humans or animals, like threatening, intimidating, or bullying others, using weapons, physically being cruel to animals or humans, as well as sexual violence. Also destruction of the property, engages in fire setting and vandalism. Serious violation of rules, running away from home, staying out past curfew, engaging in truancy, often before 13 years old. Deceitfulness or theft, lies to obtain goods and favors, breaks into buildings, cars, or homes, steals property of others, and lacks remorse for its actions. Also under 18 years old is part of the diagnostic criteria, so they must be under 18 to be conduct disorder. And if they're over 18, it's antisocial personality disorder. So for management, it's a multimodal approach for these under 18-year-olds. Behavioral modifications, community and family involvement, parent management training, enforcing the rules and setting limits. But remember, it's just behavioral modifications here for conduct disorder. There's differentiating factors between a good and poor prognosis. For a good prognosis, they'll have a positive relationship with at least one parent, adolescent onset of symptoms, so they're younger when the symptoms have an onset. Also, female gender has a better prognosis, good interpersonal skills, high IQ, and good academic performance. If they have a poor prognosis, it's typically with the onset of symptoms prior to 10 years, low IQ, or poor academic performance. So for exam tip, both oppositional defiant disorder and disruptive mood dysregulation disorder are associated with a disruptive and angry child, blaming others or refusing to follow rules. However, ODD is associated with the intent behind the behavior, and children with disruptive mood dysregulation disorder do not do it on purpose and may feel remorseful after the outbursts. So very different with the intent there. And that leads into the next disorder is oppositional defiant disorder. So this is a disorder in which children are generally defiant towards authority, but it is not associated with physical aggression, violating others' basic rights, or breaking laws, unlike conduct disorder rather. So it's a disorder in which children are generally defiant towards authority, but it is not associated with physical aggression, violating others' basic rights, or breaking any laws. It's a persistent pattern of negative, angry, or irritable mood, argumentative or defiant behavior, and intentional vindictiveness or spitefulness. 50% are associated with ADHD, and it may occasionally lead to conduct disorder. The diagnostic criteria of ODD is characterized by at least 4 symptoms, which are present for at least 6 months, with at least one individual that is not a sibling. Angry or irritable mood, loses temper, angry or resentful, also blames others for their misbehaviors and negative attitudes. Argumentative or defiant behavior, they break rules, often blames others for their behaviors, argues with authority, and deliberately annoys others. Vindictiveness, spiteful at least 2 times in the past 6 months as well. And the management is psychotherapy, behavioral modification therapy, problem-solving skills, and conflict management training, and teaching parents child management, like parenting skills, parent-child interaction therapy. Next will be the dissociative disorders. So the dissociative disorders. A dissociation is a loss or impairment of self, temporary alteration in consciousness, memory, personality, behavior, and motor function, causes impairment of typical functioning. Dissociative identity disorder. A dissociative identity disorder, or DID, is a presence of greater than 2 distinct identities or states of personalities that take control of behavior. It was formerly known as multiple personality disorder. The symptoms of disruption of the identity may be self-reported or observed by others. Gaps in the recall or events may occur for every day and is not just a traumatic event. Most common in women, may be associated with history of sexual abuse, PTSD, or substance use. There's also depersonalization or derealization disorder. Persistent feelings of detachment or estrangement from oneself, which is depersonalization, such as feelings of out of the body, and or surrounding environment, derealization. During these experiences, reality testing is intact and the symptoms cause distress. There's also dissociative amnesia. Dissociative amnesia is the inability to recall personal or autobiographical information. Often secondary to sexual abuse, stress, or trauma, it causes significant impairment in functioning. Importantly to know is about the dissociative fugue. This is an abrupt change in actual geographic location with loss of identity or inability to recall the past. So before determining this diagnosis, neurologic testing must be done to rule out if there is any seizures or brain tumor as a cause. So they often bring up dissociative fugue as a person that finds himself in a random place and they don't know who they are. Management of dissociative disorders, psychotherapy. Next, feeding and eating disorders. So obesity. Obesity is defined as a BMI, body mass index, of over 30 kilograms per meter squared, or greater, or a body weight of 20% or greater of the over ideal weight. Complications of obesity are a variety. Obesity is associated with an increased risk of coronary artery disease, diabetes type 2, breast and colon cancers. About 50% of patients experience binge eating episodes as well. Management of obesity is behavioral modifications first and foremost, with exercise and dietary changes as well as group therapy. Also medical therapy with antidepressants if there are underlying depression, and you can treat any complications as well. Anti-obesity medications, importantly to know, orlistat. Orlistat decreases GI fat digestion, and loccaserin, which is a serotonin agonist. So loccaserin and orlistat. Surgical options include bypass surgery, gastric sleeve, gastric banding, and bariatric surgery. And the USPSTF recommends screening all adults and children aged 6 years and older. So LOP, loperamide, orlistat, and phentermine as well. Binge eating disorders. Diagnostic criteria for binge eating disorders are recurrent episodes of binge eating, recurrent episodes characterized by eating within a 2-hour period more than a person would in a similar period, with a lack of control during an overeating episode. This occurs at least weekly for at least 3 months. So recurrent episodes of binge eating, at least weekly for at least 3 months for binge eating disorder. Severe distress over the binge eating, and it also may be triggered by stress or mood changes, and the patients are also often obese. However, unlike bulimia nervosa, binge eating episodes are not associated with compensatory behaviors, such as purging or restrictive behaviors, and they are not as fixated on their body shape or weight. Management, psychotherapy, CBT, interpersonal, dialectic behavioral, strict diet and exercise plan, topiramate, anti-epileptic associated with weight loss, stimulants, appetite suppressants like lisdexamfetamine and amphetamines, and don't forget topiramate, so Topamax. This is an anti-epileptic associated with weight loss. Next will be bulimia nervosa. Bulimia nervosa is an ego dystonic thing, which you don't like what you're doing, whereas opposed to anorexia is an ego syntonic, where the ego is okay with what it's doing. So bulimia nervosa, eating disorder characterized by frequent binge eating combined with compensatory behaviors to prevent weight gain. Unlike anorexia nervosa, patients with bulimia nervosa usually maintain a normal weight or may be overweight, and their compensatory behaviors are ego dystonic, as we said. They're troublesome to the patient, and the patient doesn't like that about themselves. It's more common in females in a 10-to-1 ratio, and the average onset is in late teens or early adulthood. You'll see teeth pitting or enamel erosion from vomiting, importantly. Also Russell's sign, which are calluses on the dorsum of the hand from self-induced vomiting. So I guess this is just from continuously scraping them against your front teeth, is what I imagine when they're self-inducing vomit. And also parotid gland hypertrophy, which makes sense as you're trying to increase the saliva to dilute any of the acid, and from that, not only reflux but vomiting. Lab findings: hypo-K, hypomagnesemia, electrolyte imbalance may lead to cardiac arrhythmias and seizures. Increased amylase, salivary gland hypertrophy, as we said, and vomiting. Metabolic alkalosis from the vomiting. Diagnostic criteria: recurrent episodes of binge eating, recurrent episodes characterized by eating within a 2-hour period more than a person would in a similar period of time, with a lack of control during that overeating episode. Again, it occurs weekly for at least 3 months, and it may be triggered by stress or mood changes. They'll also have compensatory behaviors, which differentiates this from binge eating disorder, where bulimia nervosa will have compensatory behaviors such as purging and non-purging. So the purging type will be primarily engaging in a self-induced vomiting. Also, it could be diuretics, laxatives, or enema abuse. Or they could be non-purging, where they're just reducing their calorie intake. They're doing excessive dieting, fasting, exercise, or diet pills. Perception of self-worth is excessively influenced by shape and body weight. For management, psychotherapy, CBT, group therapy, interpersonal therapy, combination psychotherapy, and pharmacotherapy are most effective. Pharmacotherapy, fluoxetine, as we remembered, they both have a U in it, fluoxetine and bulimia is the only FDA-approved medication for bulimia nervosa. It has been shown to reduce the binge-purge cycle. Fluoxetine is associated with a cardiovascular adverse effect, especially if electrolyte abnormalities are present. Next, we'll move to an egosyntonic behavioral syndrome, which is anorexia nervosa. Anorexia nervosa is a failure to maintain a normal body weight, unlike bulimia. It has fear and preoccupation with body weight, image, and being thin. Most common in teenage girls, age 14 to 18, and 90% are women. Frequently seen in athletes and dancers or other conditions requiring thinness, and 60% have an incidence of depression as well. Importantly, anorexia nervosa has the highest mortality rate of all psychiatric conditions due to arrhythmias at 5 to 18%. So again, anorexia nervosa has the highest rate of mortality of all psychiatric conditions due to arrhythmias from electrolyte disturbances. Clinical manifestations of anorexia nervosa exhibits behaviors targeted at maintaining a low body weight or certain image, also excess water intake, food-related obsessions like hoarding or collecting. Anorexia nervosa is an egosyntonic. Their behaviors are acceptable to them and are in harmony with their self-image goals. They could be a restrictive type, in which they're doing strict, reducing calorie intake, dieting, fasting, excessive exercise, and diet pills. Or it could be a binge eating and purging type, where primarily they're engaging in a self-induced vomit, as well as a diuretic, laxative use, or enema abuse. On physical exam of anorexia nervosa, they'll be emaciated, hypotensive, bradycardic, skin and hair changes, which is called lanugo, dry skin, salivary gland hypertrophy, amenorrhea, arrhythmias, and osteopenia. So it's important to know amenorrhea and also lanugo, which is that skin or hair changes. They again will have Russell's sign, which is the calluses in the dorsum of the hand from the self-induced vomiting, and the BMI, the body mass index of 17.5 or less, or a body weight under 85% of the ideal weight. So BMI is diagnostic at 17.5 or less, but you want to hospitalize them if their BMI is under 15. For diagnostic criteria, restriction of calorie intake relative to requirements leading to significantly low body weight, less than minimally normal. Also intense morbid fear of fatness or gaining weight, or persistent behaviors to prevent weight gain. Distorted body image, self-perception of being overweight even though they are underweight. Labs, hypokalemia due to the GI losses from laxatives or vomiting. Also increased BUN due to dehydration, and a hypochloremic metabolic alkalosis from vomiting all up the acid, as well as the chlorine. Hydrochloric acids in the stomach, vomiting up all that will decrease the ratio, leading to an alkalosis. Hypogonadotropic hypogonadism as well, which is from low estrogen, and hypothyroid too. Management of anorexia nervosa, medically stabilize them, hospitalization for under 75% expected body weight, or patients who have a medical complication, especially dehydration. And electrolyte imbalances may lead to cardiac arrhythmias, and that's why this condition is so fatal. Also, nutritional rehabilitation, of course. This is the most common complication, which is refeeding syndrome actually, which is increased insulin levels leads to a hypophosphatemia and a cardiac complications. So decreased phosphate, also decreased potassium because insulin takes it in with glucose. Psychotherapy, cognitive behavioral therapy, supervised meals, and weight monitoring. So they always ask about in anorexia nervosa what electrolyte abnormality we have, and typically it's hypophosphatemia. Pharmacotherapy, if they are depressed, SSRIs, which may also help with weight gain, and also atypical antipsychotics, which may also help with weight gain. So next will be the obsessive-compulsive and related disorders. These include obsessive-compulsive disorder itself, body dysmorphic disorder, hoarding disorder, trichotillomania, which is a hair-pulling disorder, and excoriation, skin-pulling disorder. So first with OCD, obsessive-compulsive disorder. There's obsessions and then there's compulsions. So obsessions are recurrent or persistent thoughts or images. These thoughts are inappropriate, intrusive, and unwanted. The patient tries to ignore or suppress the obsessions. They are actually ego-dystonic. They're inconsistent with the patient's own personal beliefs. For compulsions, these are repetitive behaviors, rituals in which the person feels driven to perform or reduce them to prevent stress from the obsession. These compulsions cause distress, impairment, or they are time-consuming, like over an hour a day. Men are equal to women in incidence, but men often present earlier in their teens. There's also a genetic component. The mean age of onset is 20 years old, with symptoms often present in adolescence. The onset is rare after 50 years for OCD. It's theorized to be an abnormal communication between the basal ganglia, orbital frontal cortex, and the anterior cingulate gyrus. So that's again, basal ganglia, orbital frontal cortex, and anterior cingulate gyrus. Serotonin is thought to be the primary neurotransmitter involved, and it may be associated with a triad of uncontrollable urges, OCD, ADHD, and tic disorders like Tourette syndrome. Clinical manifestations come in 4 different major patterns. This is CPSI, contamination, pathologic doubt, symmetry or precision, and intrusive obsessive thoughts. So C for contamination. Compulsion may include cleaning or hand washing. Pathologic doubt, forgetting to unplug the iron to avoid a potential danger, for instance. Symmetry and precision, ordering and counting. And intrusive obsessive thoughts without compulsion. There are some also specifiers, good and fair insight, so they could recognize their OCD beliefs are not true or may not be true, or they could have poor insight if they have OCD. They may think the OCD beliefs are probably true, or if they have completely absent insight or they're completely delusional in their belief, where they're completely convinced that the OCD beliefs are true. For management of OCD, you want to do a combination of CBT and pharmacotherapy. For cognitive behavioral therapy, first-line therapy, exposure and response prevention. So that's of the subset of CBT, you want to do exposure and response prevention. Pharmacotherapy, SSRIs are the first-line medical therapy, fluoxetine, sertraline, paroxetine, and higher doses are needed in comparison to depressive disorders like tricyclic antidepressants. Like we said earlier in the TCAs, clomipramine, because it is the most serotonin specific, is used for this disorder. SNRIs and augmentation therapy for antipsychotics. So although we specified clomipramine as the most important TCA for OCD, we still want to know that SSRIs are the first line. So sometimes they'll give you a question and it's OCD and they say, what's the first line treatment? You still want to pick the SSRI, even though we know that clomipramine might be there, but it is a TCA. So you still want to pick the SSRI in that situation. Severely debilitating or resistant, psychosurgery. You can do a cingulotomy for the anterior cingulate gyrus or electroconvulsive therapy as well. Next will be body dysmorphic disorder. This is excessive preoccupation with at least one perceived flaw or defect in physical appearance that is not observable by others or appears slight to others. This preoccupation often causes them to be ashamed or feel self-conscious, leading to a functional impairment with significant distress. May commit repetitive acts in response to this preoccupation, such as a physical flaw or defect, like mirror checking or seeking reassurance or mental acts compared to others. Average onset is 15 years of age, and it may be associated with anxiety disorder or depression. Management, antidepressants like SSRIs or CBT. You could also use TCAs, clomipramine, because this is also within the subcategory of obsessive compulsive and related disorders, and also alternative SSRIs. Next will be trichotillomania. Trichotillomania is a hair-pulling disorder. It actually is found in 1 to 2% of the adult population. Risk factors are more common in women in a 10-to-1 ratio. It has an increased incidence in OCD and excoriation disorders like skin picking disorder and depressive disorders. Clinical manifestations: hair loss, usually involving the scalp, eyebrows, eyelashes, but can be hair loss anywhere. On physical exam, decreased hair density, coarse hairs in affected areas, and hairs of differing lengths. Diagnostic criteria: recurrent pulling of hair, resulting in hair loss, repeated attempts to stop or minimize the hair pulling, and it's not due to another medication or psychiatric disorder. For management of trichotillomania, cognitive behavioral therapy, habit reversal therapy, you can use SSRI, second-generation antipsychotics, or lithium. For hoarding disorder is a persistent difficulty discarding possessions, regardless of the value, resulting in accumulation of a large number of possessions that may clutter living spaces to the point where they become unusable. The issue is due to a need to save possessions with disregard or distress associated with discarding them. Hoarding causes impairment of social, occupational, or other areas of function. For risk factors, it's most prevalent in the older population, but behavior often begins in the early teens, and also 20% have associated OCD. For management, CBT, which is very difficult to treat. So cognitive behavioral therapy is specific to hoarding, but it's very difficult to treat. SSRIs can be done, not as effective, however, unless there's concurrent OCD as well. We'll continue with neurodevelopmental disorders. This will be attention deficit disorder and attention deficit hyperactivity disorder, ADHD. So this is a neurodevelopmental disorder characterized by problems in paying attention, impulsivity, which is difficulty controlling behaviors, and hyperactivity that is not age appropriate. May continue to have symptoms as adults. Inattentiveness in adults is greater than the hyperactive type, and 60% have a comorbidity with conduct and oppositional defiant disorders as well. There's 3 subcategories of ADD and ADHD. There's the predominantly inattentive, the predominantly hyperactive and impulsive, or a combined type. For the diagnostic criteria, it's important to know the symptoms must be developmentally inappropriate for the age, have symptoms of onset before 12 years old, and must be present for at least 6 months. Symptoms must occur in at least 2 settings as well. So at least 6 inattentive symptoms and or at least 6 hyperactive or impulse symptoms. So before 12 years old, at least 6 months of duration, and at least 2 settings. So 2, 6, and 12. So the inattentive, they're easily distracted. They miss details, frequently switches from one activity to another, forgets things, is easily distracted with multiple things that are happening at the same time, has difficulty maintaining focus on one task or learning something new, misses details and may make careless mistakes, forgets things or loses things like pencils needed to complete activities or tasks, difficulty in completing assignments, becoming bored with tasks after a few minutes unless they're doing something enjoyable. Or the hyperactivity or impulsive type does things such as fidgets and squirms in their seat, constantly in motion, may often leave their seat, talks nonstop or excessively, impatience, dashes around, touching or playing with everything in sight, has trouble sitting for long periods of time, like doing homework, dinner, or school, difficulty doing quiet tasks, restlessness, as well as blurting out inappropriate or at inappropriate times, showing unrestrained emotions, and interrupts the conversation or activities of others. So there's a multimodal approach towards management. Starts with behavior modification, including social skills training, classroom modifications, and parent psychoeducation. Stimulants are the first-line medical treatment of choice, such as methylphenidate, amphetamine, dextroamphetamine, or dexmethylphenidate. There's also non-stimulants like atomoxetine, which is a norepinephrine reuptake inhibitor, which has some side effects, atomoxetine does, of dry mouth and decreased appetite and insomnia. There's also some adjunctive medications like alpha agonists, such as guanfacine or clonidine. Also, bupropion and venlafaxine can be used too. So we'll go a little bit more into the management of ADHD and ADD. So again, a multimodal approach. Behavioral modifications include social skills training, classroom modifications, and parent psychoeducation. And for those stimulants again, methylphenidate, amphetamine, dextroamphetamine, and dexmethylphenidate. The mechanism is a stimulant. It blocks the reuptake and increases the release of norepinephrine and dopamine in the extraneuronal space, sympathomimetic. It's indicated as a first-line medical treatment for ADD and ADHD. Also could be used for narcolepsy as well as excessive daytime sleepiness. Adverse effects: abdominal pain, interestingly bolded, insomnia, weight loss, dizziness, vomiting, anxiety, hypertension, tachycardia, growth delays, and addiction. You can also use non-stimulants as well, such as atomoxetine. Atomoxetine, the mechanism of action is a selective norepi reuptake inhibitor, so an SNERI, similar efficacy and adverse effect profile as stimulants, but less adverse effects and less addictive ability as well. Adverse effects again are dry mouth, decreased appetite, insomnia, and some other alternatives like we mentioned, alpha-2 agonists, guanfacine, clonidine. These drugs can also be used in Tourette syndrome as well, and bupropion, which is an NDRI, or venlafaxine, an SNRI. So next will be autism spectrum disorder. Autism spectrum disorder is a spectrum of developmental disorders characterized by impairment in social interaction or communication, restricted, repetitive, stereotype behaviors, as well as other signs leading to impaired social functioning. It's much more common in males at a 4:1 ratio, and should be suspected if there's a rapid deterioration of social or language skills during the first 2 years of life. Symptoms are usually recognized between 12 and 24 months old. So remember, that's when you can do the MCHAT at 18 and 24 months. So these symptoms are usually recognized between 12 and 24 months old. The diagnostic criteria: social interaction difficulties is classic. Significant emotional discomfort or detachment, such as avoiding eye contact, no response to cuddling or affection. Impaired communication, either inability to communicate or has the ability to communicate but chooses not to in social settings. Difficulties in understanding what is not explicitly stated, like metaphors or humor and jokes, so they're very literal. Restricted, repetitive, and stereotype behaviors. So these are patterns of activities like particular interests in objects, rigid or inflexible thought patterns, and also repetitive motor patterns as well. So for autism, they also have some other signs like persistent failure to develop social relationships, failure to show preference to parents over other adults, unusual sensitivity to visual, auditory, or olfactory stimuli, unusual attachments to ordinary objects as well. Also savantism, like unusual talents. These disturbances are not better explained by intellectual disability, intellectual development disorder, or global developmental delay. For management of autism, you want to have referral to a neuropsychologist for testing and behavioral modification strategies and medications. Next, for different personality disorders. So personality disorders comprise 10 to 15% of the overall population. They're pervasive, inflexible personality traits causing a variety of impaired functioning and distress. So we'll start with cluster A personalities. And cluster A personalities include social detachment with unusual behaviors. So these are the weird, odd, and eccentric behaviors. So this is schizoid, schizotypal, and paranoid personality disorder. So first, schizoid. This is a lifelong pattern of voluntary social withdrawal and anhedonic introversion. So they have a constricted affect. It's most common in males, and it's usually early in childhood onset. So think schizoids avoid. So AVOID, anhedonic, voluntary social withdrawal, odd, introverted, and detached. So A for anhedonic for schizoid personality disorder. Anhedonic is little pleasure in activities, appears indifferent, and lacks response to praise or criticism. For voluntary social withdrawal, prefers to be alone, unlike avoidant personality disorder. So these people just want to be alone. In avoidant personality disorder, that's different. No desire for close or sexual relationships, and prefers solitary activities. For odd, they're appearing or eccentric. Introverted, they're a loner and hermit-like behavior, as well as quiet. Detached, flat, cold, and constricted affect. For management, psychotherapy includes individual or group therapy as the first-line management, and pharmacologic plus or minus short-term low-dose antipsychotics, antidepressants, or psychostimulants. Next will be schizotypal personality disorder. This is a bit different. This is characterized by odd, eccentric, bizarre behavior and thought patterns suggestive of schizophrenia without psychosis. So in this one, there's no delusions or hallucinations. Usually early in adulthood onset, small percentage may develop schizophrenia. The diagnostic criteria, at least 5 of the following. Ideas of reference, so that excluding delusions of reference, however, and a suspiciousness about people. They have odd beliefs or classic magical thinking with schizotypal, or speech, beliefs in clairvoyance, telepathy, superstition, or bizarre fantasies, may talk to themselves in public, have unusual perceptual experiences, distorted cognition or reasoning, inappropriate or restricted affect, and pervasive discomfort with close relationships, increased social anxiety, may have very few close friends. For management of schizotypal, it's psychotherapy again is the first line, cognitive, behavioral, individual, or group therapy. Pharmacologic, again, short-term, low-dose antipsychotics for psychotic episodes or suspiciousness. So next will be paranoid personality disorder. This is the last one in the cluster A. So cluster A again, schizoid, schizotypal, and paranoid. So paranoid is pervasive pattern of distrust and suspiciousness of others. It begins in early adulthood, more common in males, more common if they have a family history of schizophrenia. There's no magical thinking in this one though. The suspicion of others with interpretation of their motives as malevolent and without sufficient basis. The preoccupation is with unjustified doubts regarding the loyalty and trustworthiness of others. There's also a reluctance to confide in others and blames their problems on others. Misinterpretation of benign remarks of others as threatening or demeaning, sees hidden messages, is easily insulted. They also bear grudges and they don't forgive. There's a perception of attack on his or her character that is not apparent to others and may react angrily to counterattack. There's suspicion regarding the faithfulness of their partner or spouse without any justification. And the management for paranoid personality disorder is, again, cognitive behavioral therapy as the first line. Patients may be suspicious of even group therapy. Again, short-term antipsychotics if severe or psychosis. So now we'll go into cluster B personality disorders. Cluster B is dramatic, wild, erratic, impulsive, and emotional. So these contain antisocial, borderline, histrionic, narcissistic. So antisocial, borderline, histrionic, and narcissistic for cluster B. So first we'll start with antisocial. Antisocial personality disorder, its behavior is deviating sharply from the norms, values, and laws of society. So they may have harmful or hostile behaviors to society. Their deceitfulness is their nature, and they may be masked and may be seen as charming or nice to those who don't know their history. They also may commit criminal acts with disregard to and violation of laws, 3 times as more common in males. For antisocial diagnostic criteria, they must be at least 18 years or older, and they must have a history by 15 years of age, consistent with conduct disorder. So interestingly, they must have a history by 15 years of age, consistent with conduct disorder. So remember that it's only conduct disorder under 18 and over 18 antisocial. But for antisocial, not only do they have to be over 18, but they must have a history by age 15 of conduct. And so they also have 3 of the following: failure to conform to social norms with disregard and violation of the rights of others, or committing unlawful acts. They'll have irritability or aggressiveness towards others, and they'll result in assaults, exploiting others for personal gain, like lying, manipulating, or deceitful acts. Also recklessness and disregard for the safety of their own self and others, like drunk driving, which is very common. Also impulsivity, lack of remorse for their actions, and irresponsibility or failure to maintain work or honor financial obligations. For management, psychotherapy, again, establishing limits is important in the psychotherapy. Otherwise, psychotherapy and pharmacotherapy generally are ineffective, and avoid medications with abuse potential for these patients with antisocial personality disorder. So again, cluster B disorders: antisocial, borderline, histrionic, and narcissistic. So we'll now move to borderline personality disorder. Borderline personality disorder is an unstable, unpredictable mood and affect. It's unstable self-image and relationships. It's most commonly seen in women. Diagnostic criteria. Think of the B's for borderline. Think of bat, mood swings, black and white thinking, thinks in extremes of all good or all bad. There's no middle ground. This is called splitting. Blown up, intense, reaction disproportionate to the event. Broken, unstable relationships, breaking up, fear of abandonment, and bad behavior, impulsivity in self-damaging behaviors, suicide, self-mutilation, substance abuse, reckless driving, binge eating, spending, bad sense of self. For management, behavioral therapy, cognitive, or dialectical, importantly, dialectical. Next will be histrionic personality disorder. Histrionic personality disorder is the H's for histrionic personality disorder. Hey, look at me. Attention seeking with the need to be the center of attention, overly emotional, dramatic, or seductive. Also hissy fits, temper tantrums, and self-absorbed. Come hither, often inappropriate, sexually provocative, or seductive. Hype me up, seeks reassurance and praise often, can be easily influenced by others. Hyperinflated, may believe their relationships are more intimate than they really are. And for management, again, behavioral therapy, cognitive, and dialectical. And lastly, for cluster B personality disorders will be the narcissistic personality disorder. This is grandiose, often excessive sense of self-importance, superiority, need for admiration, and lack of empathy. Despite this exaggerated self-importance, they may have a fragile self-esteem, difficulty with the aging process, loss of power, high incidence of midlife crises, and may become depressed when they don't get the recognition they feel they deserve. Some of the manifestations of narcissistic personality disorder are an inflated self-image, the belief that he or she is special, entitled, or required to extra special admiration, preoccupation with fantasies of brilliance, wealth, or success, takes advantage of or exploits others for self-gain, recognition or status, arrogance, envy of others or belief that others are envious of them, lacks empathy for others, may react to rejection or criticisms with rage. Psychotherapy is the initial treatment of choice, CBT especially, individual or group therapy as well. So moving to cluster C personality disorders. This is the anxious, worried, and fearful. So it's avoidant personality disorder, dependent personality disorder, obsessive compulsive personality disorder, which is different from OCD, and that's it. So avoidant, dependent, and obsessive compulsive. So for avoidant personality disorder, it's characterized by social inhibition due to an intense fear of rejection, affecting their daily lives. Timid, shy, and lacks confidence. The diagnostic criteria are patterns of hypersensitivity, social inhibition, and feelings of inferiority or inadequacy, and at least 4 of the following. Unwilling to interact with others unless certain of being liked. Avoids occupations that require interpersonal contact due to fear of rejection and criticism. Cautious of interpersonal relationships, inferiority or inadequacy complex. Averseness to participate in new activities due to fear of embarrassment. Preoccupation with being rejected in social situations. And management, again, psychotherapy. Dependent personality disorder. Dependent personality disorder is characterized by the inability to assume responsibility, dependent or submissive behavior, fear of being alone, and difficulty making day-to-day decisions. The diagnostic criteria is patterns of excessive need to be taken care of, leading to needy or clingy behavior, characterized by at least 5 of the following: the need for others to assume responsibilities for most things in life, difficulty in expressing disagreement for fear or decreased approval, difficulty making day-to-day decisions without external help, often will not initiate things or may volunteer for unpleasant tasks, feeling of helplessness and intense discomfort when they are alone, with a quickness to enter a relationship after one ends. Also preoccupation with fears of being left to take care of their own self. Goes to extreme lengths to obtain approval from others. And for management, psychotherapy, CBT, with social skills training and assertiveness skills treatment of choice. And lastly, for cluster C is obsessive compulsive personality disorder, not to be confused with obsessive-compulsive disorder itself. So, obsessive-compulsive personality disorder is characterized by preoccupation with order, detail, and perfectionism without obsession or compulsion. Their behavior is egosyntonic. They don't see anything wrong with their behavior. They believe it's necessary, and it's 2 times more common in men as well. Whereas OCD is mostly ego-dystonic. They just kind of are compulsed to do what they have to do, but this is syntonic and they feel like it's necessary. So the diagnostic criteria are a preoccupation with order, details, perfectionism, characterized by at least 4 of the following: perfectionism that may make completion of a task difficult or in a timely fashion difficult; preoccupation with rules, lists, minute details, and organization that the primary goal of the activity is lost; hesitance to delegate tasks to others; extreme devotion to work, morals, or ethics; rigid, stubborn, serious, or restricted affect; inability to discard useless objects as well. Management is psychotherapy, social training, CBT, or group therapy, and pharmacotherapy can be beta blockers for anxiety or SSRIs for depression. Next will be psychoses. First, delusional disorder. Delusional disorder. Delusion is a fixed belief, despite evidence of the contrary. A non-bizarre delusion is a false plus a plausible but highly unlikely thing, like being poisoned. Criteria for delusional disorder: at least 1 delusion lasting at least 1 month without other psychotic symptoms and no significant impairment in function. So delusional disorder, 1 delusion, 1 month at least, without other psychotic symptoms and no impairment in function. Apart from the delusion, the behavior is not obviously odd or bizarre, and there is no significant impairment of function. It does not meet the criteria for schizophrenia, and it's not explained by another disorder, substance, or medication. The management is with atypical second-generation antipsychotics for the first-line medical management, and psychotherapy may be additive in some patients, with the exception of group therapy, which they shouldn't do. For psychotic disorders, there's a few different ones, and we have to understand the differences. Psychotic disorders are a disorder of abnormal thinking, behavior, and emotion. Schizophrenia, the diagnostic criteria of 2 or more of the following: positive symptoms, negative symptoms, and grossly disorganized or catatonic behavior for at least 6 months. So schizophrenia has to be positive, negative, or grossly disorganized or catatonic behavior for at least 6 months. It needs 2 or more of the following. Schizophreniform is symptoms of schizophrenia, but the duration is only 1 to 6 months. Brief psychotic disorder is kind of psychosis with onset and remission under 1 month. And schizoaffective is schizophrenia, so therefore over 6 months, plus a mood disorder, major depressive or manic. So again, schizophrenia, 2 or more of the following for at least 6 months. Schizophreniform, 1 to 6 months. Brief psychotic disorder, under 1 month. Schizoaffective, schizophrenia, therefore at least 6 months, plus a mood disorder, major depressive or manic. Now moving into schizophrenia itself. Schizophrenia is a disorder of abnormal thinking, behavior, and emotion. It's actually 1% of the population, and men and women are affected equally, but men present early to the mid-20s, compared to the late 20s also seen in women, as seen in women. It's rarely initially presenting before age 15 or after age 55. So men tend to have more negative symptoms and a poorer outcome. It is a very strong genetic predisposition, with 50% concordance among monozygotic twins, 40% risk if both parents have schizophrenia, and 12% risk if the first-degree relative is affected. Substance use is very common also with schizophrenia. Nicotine is the most common at over 50%, alcohol, cannabis, and cocaine. For a better prognosis versus a worse prognosis, a better prognosis will be later age at onset, acute onset, positive symptoms, they'll have good social support, female gender, few relapses, good pre-morbid function, mood symptoms, and no family history of mental illness. They'll have a worse prognosis if the early age of onset, gradual onset, or negative symptoms, or poor social support, male gender, and also many relapses, and poor pre-morbid function. The pathophysiology, the exact cause is unknown, but the positive symptoms are thought to be due to the excess of dopamine in the mesolimbic pathway, with negative symptoms due to dopamine imbalance in the mesocortical pathway. So negative symptoms, dopamine imbalance, mesocortical. Positive symptoms, dopamine excess, and the mesolimbic. For the diagnostic criteria of schizophrenia, you need 2 or more of the following: positive symptoms, which are hallucinations, delusions, or disorganized speech, or negative symptoms, or grossly disorganized or catatonic behavior, again for at least 6 months. At least one must be a hallucination, delusion, or a disorganized speech, and must manifest for at least 1 month period. Must impair function as well. And also the symptoms must not be due to a substance or medical condition. So we'll go into the difference between hallucinations and delusions. So hallucinations are sensory perception without a physical stimuli. So they can be auditory, which is the most common type of hallucination. This is a sound or a voice heard in the third person, or it can be a command hallucination. Visual, they may have some flashing lights or seeing faces. Olfactory, with smells. Tactile, insects or skin being touched. Somatic, sensing or sense arising from within the body. Or gustatory, can be part of the persecutory delusions, like tasting poison in the food. Delusions next. Delusions are a fixed belief held with a strong conviction despite evidence to the contrary. So a persecutory delusion is the most common. It's a person or force interfering with them, observing them, or wishing to harm them. There's also delusions of reference. These are random events that take on a personal significance directed at them. There's control delusions. Some agency takes control of the patient's thoughts, feelings, and behaviors. There's also grandiose, a very common one. Grandiose delusions, which are unrealistic beliefs in one's powers and abilities. There's nihilism, exaggerated belief in the futility of everything and catastrophic events. There's erotomania delusion, belief of another person is in love with them. There's jealousy, somebody is suspected of being unfaithful. There's doubles, believes a family member or a close person has been replaced by an identical double delusion. So to go over some of the positive symptoms, positive symptoms really means these symptoms are added to the normal behavior. These are hallucinations, delusions, disorganized speech again. So the hallucinations, again, are sensory perception without a physical stimuli. The auditory is most common type of hallucination. And for delusions, they're firm, fixed beliefs despite evidence to the contrary. Persecutory, grandiose are the most common. For disorganized speech, thoughts are disconnected and tangential rambling. Also behavioral disturbances. For negative symptoms, these symptoms are taken away from normal behavior. So the absence of normal cognition, the affect flattening, alogia, which is poverty of speech, increased latency of response, avolition, a lack of will, anhedonia, and asociality. Not part of the diagnostic criteria, but findings asked on exams are what would you see on neuroimaging. So on CT for schizophrenia, you see ventricular enlargement in the lateral and third ventricles, importantly, as well as a decreased cortical volume in gray matter. So CT, ventricular enlargement, as well as decreased cortical volume in gray matter. On a PET scan, you see a hypoactive frontal lobe and hyperactivity in the basal ganglia. So how do we manage schizophrenia? Second generation atypical antipsychotics are first line: risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, and lurasidone. The mechanism are dopamine antagonists, D4 over D2, and serotonin HT2 antagonists. So they have a lower risk of extrapyramidal symptoms, but increased risk of metabolic adverse effects. Clozapine is not used in first line, but it is the most effective medication for treatment-resistant psychosis. And this is only done after 2 medications have been tried, second gens, that is. And medication should be tried for at least 4 weeks before efficacy is determined. So to talk about the first generation typical antipsychotics, like haloperidol, droperidol, fluphenazine, chlorpromazine, perfenazine, and thioridazine. Most effective drugs for positive symptoms. Minimal effect on negative symptoms, but increased risk of EPS, extrapyramidal symptoms, especially tardive dyskinesia, neuroleptic malignant syndrome as well. And these patients, well, we'll go into them further. Behavioral therapy and family therapy also can be used. Long-acting IM versions, you can use risperidone, fluphenazine, etc. Also, lithium can be used sometimes. For acute psychosis, if they're extremely agitated and psychotic, haloperidol, risperidone, paliperidone can be used. Also, you want to hospitalize them, get a urine tox, and rule out substance abuse, CBC, Chem7, LFTs, EKG, especially with that QT interval prolongation, and also fasting. For emergency in acute psychosis, if they're extremely agitated and psychotic, you can do an intramuscular ziprasidone, olanzapine, or aripiprazole. IM haloperidol may be used, but it has more adverse effects. Antipsychotics, and some specific facts about each of the antipsychotics. So, risperidone. Risperidone is one of the most commonly used agents prescribed for schizophrenia. It's a long-acting injectable, and it has greater incidence for movement disorders. For quetiapine, it has a lower incidence of movement disorders, EPS. Olanzapine has the highest or higher incidence of weight gain and diabetes. So olanzapine and clozapine have the highest risk of metabolic abnormalities. So olanzapine, clozapine. Clozapine is not used first line due to the increased risk of agranulocytosis and myocarditis. Very important. Agranulocytosis and myocarditis for clozapine. However, it is the best drug for medication refractory schizophrenia, clozapine is. And also has a decreased incidence of suicide for clozapine. Ziprasidone is the highest risk of QT prolongation, less likely to cause significant weight gain, however. Aripiprazole has a unique mechanism. It's a partial dopamine agonist, actually. Has less potential for weight gain and less sedative. Lorazepam, safer for use in pregnancy, and can be used in bipolar depression. So we'll go over some overall adverse effects of antipsychotics. EPS, extrapyramidal symptoms. These are due to a dopamine blockade in the nigrostriatal pathway. Acute dystonia, spasms, or sustained contractions of the neck or face, trismus, protrusions of the tongue, facial grimacing, torticollis, and difficulty speaking. It usually occurs, however, from hours to days after initiating the medication. Acute management, you want to use diphenhydramine or benztropine, so they have anticholinergic and antihistaminic effects. For akathisia, feelings of restlessness. Management, reduction of the dose or switch meds. Beta blockers can be used for the akathisia, such as propranolol, non-selective. Also, it's the first-line management. You can also use the benztropine as well and the benzodiazepines. For Parkinsonism, which is tremor, rigidity, and bradykinesia as the side effect, and there's also tardive dyskinesia, which is repetitive involuntary movements mostly involving the face, such as lip smacking, teeth grinding, and rolling of the tongue, seen with long-term use, especially first generation. There's also some other adverse effects with antipsychotics, such as increased prolactin, very important, dopamine blockade in the tuberoinfundibular pathway, more common with first generation, however. Metabolic as well, hyperlipidemia, weight gain, hyperglycemia, and increased abdominal fat. It's more common with the second gen, though, to have metabolic side effects. And aripiprazole and ziprasidone are the least associated with metabolic changes, but remember, ziprasidone has the highest rate of prolonged QT. Neuroleptic malignant syndrome, NMS. So neuroleptic malignant syndrome is an altered mental status and a lead pipe, quote unquote, lead pipe muscle rigidity. It also has autonomic instability, tachycardia, tachypnea, hyperthermia, fever, blood pressure changes, hypersalivation, and diaphoresis. Also incontinence, leukocytosis, and rhabdomyolysis with increased creatine phosphokinase, CPK, LDH, and LFTs. The management of NMS is prompt discontinuation of the medication, which is the most important first step always, and supportive care like cooling blankets, IV fluids. Dopamine agonists can be used. Bromocriptine, amantadine, and dantrolene can be used for rigidity and fevers as they may be needed. So remember, we need to know the difference between NMS, neuroleptic malignant syndrome, and serotonin syndrome, and what's the difference in treatment too. So NMS is bad, B-A-D. So that's what I think about for the medication treatments. So bromocriptine, amantadine, and dantrolene. That's the treatment for NMS. So that differs from serotonin syndrome, which the treatment is cyproheptadine as well as a benzo. So different treatments for NMS versus serotonin syndrome. Also, for antipsychotic side effects, QT prolongation, like we said, arrhythmias and seizures, and rash. Anti-HAM effects, antihistaminic, antiadrenergic, and antimuscarinic, which are anticholinergic effects as well. And that's more common with the first gens too. Some of these anticholinergic effects are dry mouth, dry eyes, blurred vision, urinary retention, constipation, and hyperthermia. Antihistaminic effects are sedation and weight gain, and anti-alpha-1 adrenergic effects are orthostatic hypotension, sexual dysfunction, and cardiac abnormalities. Next, we'll transition to trauma and stress-related disorders. So PTSD, post-traumatic stress disorder. PTSD, the diagnostic criteria is exposure to an actual or threatened death, serious injury, or sexual violence via a direct experience of the traumatic event, or witnessing of the event in person, or learning the event has happened to someone close, like a family member or friend, or experiencing extreme or repeated exposure to aversive details of traumatic events like first responders collecting human remains, or war, or natural disasters. Traumatic events occurring any time in the past. It can be any time in the past for PTSD. It presents with at least one of the following of the intrusive symptoms after the event, which may lead to significant distress or impairment in function, occupational, social, or other areas. They may experience re-experiencing, which is greater than 1 month, as repetitive recollections, distressing dreams, and dissociative reactions, importantly. Dissociative reactions for over 1 month, such as flashbacks in which the person feels and acts as if the event is recurring, leading to physiologic distress and or physiologic reactions. They'll also experience avoidance of stimuli associated with the traumatic event, like reminders of those specific events. And also at least two negative alterations in cognition and mood must be present for diagnosis of PTSD. So 2 negative alterations in cognition and mood, such as inability to remember an important aspect of the event. They may have some dissociative amnesia, negative feelings of self, world, or other, anhedonia, negative emotions like horror, guilt, anger, or shame, feelings of detachment, or inability to experience positive emotions. At least 2 arousal and reactivity symptoms, like angry outbursts, irritable behavior, reckless or self-destructive behaviors, hypervigilance, sleep disturbances, and concentration issues, as well as exaggerated startle response. So exaggerated startle response. Management is SSRIs as the first-line medical treatment. Paroxetine, sertraline, fluoxetine. TCAs can be used, MAOIs as well. Trazodone may be helpful for the insomnia, importantly, trazodone for the insomnia, and CBT, so psychotherapy including individual or group relaxation techniques as well. And prazosin, interestingly, may be used for nightmares and hypervigilance. So trazodone for the insomnia and prazosin, interestingly, for the nightmares and hypervigilance. So now we'll go to acute stress disorder. So acute stress disorder is, for the diagnosis, similar to PTSD, except the traumatic event occurred under 1 month ago and the symptoms lasted under 1 month. So acute stress disorder under 1 month, PTSD over 1 month. Symptoms are very similar, include intrusive symptoms, avoidance, increased arousal, and negative alterations in thought and mood. Management is counseling and psychotherapy is first line for acute stress disorder. Because the definition of the symptoms will resolve in 1 month, you're not going to treat them with medications. If symptoms are over 1 month, then it's PTSD. So again, acute stress disorder, trauma occurs under 1 month, plus symptoms are under 1 month in duration. PTSD, trauma occurred at any time in the past, plus symptoms for over 1 month. Okay, so next will be adjustment disorder. Adjustment disorder is a maladaptive emotional or behavioral reaction to an identifiable stressor, like a job loss, a physical illness, leaving home or divorce, or a non-life-threatening event that may cause a disproportionate response that would normally be expected within 3 months of the stressor. It does not include bereavement, importantly, and usually resolves within 6 months of the stressor. So, usually resolves within 6 months. It's a maladaptive emotional and behavioral reaction to an identifiable stressor, and it's a disproportionate response that would normally be expected within 3 months. of the stressor. Okay. Clinical manifestations, one or both of the following: some marked distress out of proportion to the severity of the stressor, and or significant impairment in the areas of functioning, like occupational, social, and it can manifest as a depressed mood, anxiety, or a disturbance in conduct. Psychotherapy is the initial management of choice, including individual or group therapy, and you should use meds in select cases, but they're not preferred. And oftentimes, for adjustment disorder, the patients are self-medicating with alcohol or other drugs. Now for somatic symptom and related disorders. So somatic symptom and related disorders are illness anxiety disorder, for instance. And formerly this was called hypochondriasis. So illness anxiety disorder or hypochondriasis, this is preoccupation with having or acquiring a serious illness despite constant reassurance and medical workups showing no disease. Again, formerly known as hypochondriasis. And for illness anxiety disorder, the patient exhibits a high level of concern and anxiety about their health. They have care-seeking types, which frequently get tested and quote-unquote doctor shop. Also, care avoidance may be seen. The age of onset is usually 20 to 30 years of age. And for diagnostic criteria, the preoccupation causes the patient to perform excessive health-related behaviors or may develop maladaptive behaviors. Their preoccupation or behaviors must last at least 6 months, and symptomatic symptoms or somatic symptoms are usually not present. So no somatic symptoms in this illness anxiety disorder. If they are present, they're mild in intensity. And it's also not explained by another disorder, like somatic symptom disorder, because there's no somatic symptoms. Management: regularly scheduled appointments with their medical provider for continued reassurance, interestingly. And you can do CBT. And also you'll find comorbid anxiety and depressive disorders, which should be treated with SSRIs or something else. Next, we'll differentiate that illness anxiety disorder from malingering. So malingering is intentional falsification or exaggeration of signs and symptoms of medical or psychiatric illnesses for an external secondary gain. So malingering and external secondary gain, and they're intentionally falsifying or exaggerating it. So things like this could be financial gain, insurance money or lawsuits, food, shelter, avoidance of prison, school, etc. Malingering is not a mental illness, and both factitious disorder and malingering are associated with an intentionally faking of signs and symptoms. The difference is that in malingering, they feign illness for secondary gain, whereas in factitious disorder, the primary motive is to assume the sick role and get sympathy. So for factitious, they just want to basically get attention. But for malingering, they want something from it, and it's not the attention. So next will be functional neurological symptom disorder. Conversion disorder, it was previously called. Functional neurologic symptom disorder. So formerly known as conversion disorder, where patients convert their psychological distress into neurologic symptoms. This is 2 to 3 times more common in women, and it's often preceded by a traumatic event. It may have comorbid depression, anxiety, or neurologic disorder. And for diagnostic criteria, at least one symptom of neurologic dysfunction, voluntary, motor, or sensory, that cannot be explained clinically and not explained by another medical or psychiatric condition. Patients are often calm or seem unconcerned about the deficits, and the symptoms are not intentionally produced or feigned. There's motor or sensory. So for motor dysfunction, for functional neurologic symptom disorder, they may have some paralysis, aphonia, mutism, seizures, gait abnormalities, involuntary movements like tics, weakness, swallowing, or a globus sensation, globus hystericus. Sensory dysfunction like blindness, anesthesia, paresthesia, visual changes and deafness can cause significant distress and or impairment in functioning, social, occupational. So for management of functional neurological symptom disorder, formerly known as conversion disorder, it's just patient education about the illness as first line. You could do CBT with or without physical therapy if education is not successful. And now we'll go to factitious disorder, and we'll compare it again to malingering. So factitious disorder, this is the intentional falsification or exaggeration of signs and symptoms of medical or psychiatric illnesses for a primary gain. So factitious disorder is primary gain, the inner need to be seen as ill or injured. There's no external reward here, such as in a secondary gain, such as seen as malingering. Factitious disorder can be imposed on yourself, which is presenting themselves as injured, impaired, or ill. It could also be a factitious disorder imposed on another. Presents another as injured, impaired, or ill, such as child, elderly, or mentally disabled family member. This is considered a form of premeditated child or elder abuse. So remember, factitious disorder on self or on another, and it's for primary gain. Some of the manifestations of factitious disorder: intentional creation or exaggeration of symptoms of illness, like they may hurt themselves to bring on symptoms, alter diagnostic tests even, lie or mimic symptoms. They may inject themselves with substances to make themselves sick, and medical history may be dramatic but inconsistent. They may be willing or eager to undergo surgery repeatedly or painful tests in order to obtain sympathy. They may hospital jump, using other aliases, or go to different cities to access care. They often have extensive knowledge about medical terminology, hospitals, or great detail about their illnesses, quote unquote. They may even work in healthcare. Diagnostic criteria: intentional falsification or exaggeration of signs and symptoms of a medical or psychiatric illness for primary gain. Motivation of their actions is to assume the sick role. Management: nonspecific treatment. Collect information from medical providers and family to avoid unnecessary procedures. May require confrontation in a non-threatening manner. When confronted, patients often leave AMA. Okay, so somatic symptom disorders next. This used to be called So next will be the somatic symptom disorder, formerly somatization disorder. This is a chronic condition in which patients have a physical symptom involving at least one body system, but there's no physical cause found in workup. So they actually do have a symptom, unlike the illness anxiety disorder, which does not actually have a symptom. So these patients with somatic symptom disorder have excessive thoughts, feelings, or behaviors related to the somatic symptom. Disproportionate or persistent thoughts about the seriousness of the symptom, persistently high level of anxiety about the symptom or health, or excessive daytime or energy devoted to the symptom and health concern. So they frequently seek the treatment from many medical providers, requesting extensive lab work, diagnostic procedures, or surgeries. They may or may not be associated with other medical conditions as well. Risk factors: most common in young women, a 10-to-1 ratio, with the onset usually before 30 years of age. They could be also older age and unemployed, history of sexual abuse, or low socioeconomic status. For diagnostic criteria, they need one or more vague physical symptoms that are distressing or result in significant disruption of daily life. These symptoms cannot be explained, however, by a physical or medical cause, and at least two symptoms increases the likelihood of a somatization disorder. So some of these symptoms are shortness of breath, dysmenorrhea, burning in a sexual organ, lump in the throat, amnesia, vomiting, and painful extremities. So although any one of the somatic symptoms may not be continuously present, the state of being symptomatic is persistent, usually over 6 months. Very importantly, over 6 months for somatic symptom, usually. Specifiers with predominant pain, previously pain in the DSM-4, and persistent. Management: regularly scheduled visits to the healthcare provider, and psychotherapy as well. So to go over some of the exam tip for the differentiation of all these disorders, these 5 disorders seem similar, so look at the clues to differentiate them. Somatic symptom disorder is an actual physical symptom, at least one body symptom, with no cause on workup and no intentional falsification. They really do believe they are ill. Functional neurologic disorder is a neurologic symptom or deficit, sensory or motor, with no cause on workup and no intentional falsifications. They believe they're ill, but they could have it or not. Illness anxiety, preoccupation 1 has an undiagnosed serious illness and no intentional falsification. They believe they're ill. Factitious disorder, an intentional falsification of symptoms for a primary gain, assuming the sick role or sympathy. And malingering is again intentional falsification of symptoms for a secondary gain, like an external gain such as money, shelter, etc. So next we'll go to drug abuse and dependence to finish up. This will start with tobacco abuse and dependence. So smoking is the most important modifiable risk factor in the U.S. for preventing pulmonary, cardiac, and cancer deaths. Smoking cessation should be discussed with all smokers at every clinical contact. They could have some nicotine withdrawal symptoms, including restlessness, anxiety, irritability, sleep abnormalities, headaches, depression, increased appetite, weight gain, chest tightness, nicotine cravings. So how do we manage this? CBT, relapse after abstinence is common, and they can do a nicotine tapering therapy, such as with gum, nasal sprays, transdermal patches, inhalers, and lozenges. For bupropion, this is an NDRI, is an antidepressant drug often used in combination with nicotine tapering therapy. The mechanism dopamine and norepi reuptake inhibitor that reduces nicotine cravings and withdrawal symptoms. You can also use varenicline. This is blocking the nicotine receptors, reducing nicotine activity. It's a partial agonist that mimics the effects of nicotine, reducing the reward effect and preventing withdrawal symptoms. Therapy should begin 1 week prior to the quit date and continue to 4 months after the quit date. Adverse effects are headache, nausea, insomnia, increased suicidality, or neuropsychiatric conditions. Bupropion. Bupropion is a mechanism of action such as antidepressant drug that often used in combination with nicotine tapering therapy, dopamine and norepinephrine reuptake inhibitor that reduces nicotine cravings and withdrawal symptoms. It's indicated in smoking cessation, and therapy should begin 1 to 2 weeks prior to the quit date and continued for 4 to 6 months after the quit date. Adverse effects are seizures, as it lowers the seizure threshold, dry mouth, insomnia, weight loss, hypertension, increased anxiety and agitation, increased risk of psychosis at higher doses, and avoid abrupt withdrawal of this medication as well. So again, contraindications, epilepsy, or conditions with an increased seizure risk, especially eating disorders like bulimia and anorexia nervosa. So bulimia, anorexia nervosa, epilepsy disorders, and avoid in patients with recent MAOI use. Caution, hypertensive and cardiovascular disease. So next will be opioid use and dependence. So opioid use and dependence, some of these medications are heroin, oxycodone, hydrocodone, codeine, morphine, dextromethorphan, meperidine, and methadone. Opioid intoxication will lead to euphoria and sedation. And physical exam findings will be pupillary constriction, narcotics are miotics, altered mental status, and respiratory depression. They may also develop biots breathing, groups of quick, shallow inspirations followed by regular or irregular periods of apnea, bradycardia, importantly, hypotension, nausea, vomiting, and flushing. Patients on long-term narcotics may develop constipation, as opioid receptors in the GI tract reduce GI motility, and hypothermia. For opioid withdrawal, importantly, these symptoms are lacrimation, hypertension, pruritus, tachycardia, nausea, vomiting, abdominal cramps, diarrhea, sweating, yawning, also piloerections, goosebumps, pupil dilation, mydriasis, flu-like symptoms as well. Rhinorrhea is classic, and pupillary dilation is classic. So the flu-like symptoms are classic for opioid withdrawal. It may also have joint pain and myalgias. Withdrawal is often unpleasant, but is not life-threatening, importantly. Management of opioid withdrawal, opioid intoxication. Naloxone is an opioid antagonist used in acute intoxications or overdose to acutely reverse the effects of opioids. The onset of action is about 2 minutes IV, about 5 minutes IM, and about 30 to 60 minutes has the duration of action. So that's important. Most commonly used in patients with respiratory depression. So you can use naloxone, but if they're still under the influence of a lot of opioids, you may need to re-administer it after that 30 to 60 minutes because they could continue after the naloxone wears off. Opioid withdrawal, symptomatic control with clonidine as it decreases the sympathetic symptoms, loperamide for the diarrhea, dicyclamine for the abdominal cramps, and NSAIDs for joint pain and muscle cramps. Benzos may be helpful in some cases of mild withdrawal. Severe symptoms can be treated with detox with methadone or buprenorphine plus naloxone. For long-term management of dependence, methadone and maintenance programs, Suboxone, buprenorphine, and naloxone or naltrexone. Opioid dependence management, methadone. The mechanism of action is a long-acting opioid receptor agonist used in the control of withdrawal from opioid in patients with opioid addiction. Can be used in pregnant opioid-dependent women and can be given orally. Adverse effects of methadone, very important to know that it can prolong the QT interval. Buprenorphine, the mechanism of action is a partial opioid receptor agonist. Suboxone is a combination of buprenorphine plus naloxone. Naloxone prevents intoxication from these IV injections, so that's why it's a combination of both. For naltrexone, the mechanism is a competitive opioid antagonist. It precipitates withdrawal if used within 7 days of heroin use. Oral or monthly depot injection. Next, for alcohol withdrawal. So uncomplicated alcohol withdrawal. The onset is 6 to 36 hours after the last drink. The times may vary, depending. Clinical manifestations are an increased CNS activity. Tremors, anxiety, irritability, diaphoresis, palpitations, hypertension, insomnia, GI, nausea, vomiting, diarrhea. Uncomplicated, no seizures, hallucinations, or delirium tremens. So with alcohol, you're constantly downregulating the GABA receptors so that when you actually take away the alcohol, there's no real inhibitory neurotransmitters there, so all you have is that sympathetic stimulation. So it's going to be really bad. Withdrawal seizures, the onset is 6 to 48 hours after the last drink. Usually generalized tonic-clonic type. Most commonly occurs as a single brief episode, however. They could have alcoholic hallucinations as well, from 12 to 48 hours after the last drink. And these clinical manifestations are visual, auditory, or tactile hallucinations. The patient has a clear sensorium and a normal vital signs. They could also progress to delirium tremens, which is 2 to 5 days after the last drink. This manifests as delirium, an altered sensorium, hallucinations, agitations, also abnormal vital signs like tachycardia, hypertension, and fever, and they could also be diaphoretic. For management of alcohol withdrawal requires medical treatment and hospitalization. Alcohol withdrawal can be fatal. IV benzos, diazepam, lorazepam, chlordiazepoxide, which is Librium, and oxazepam. Mechanisms potentiates GABA-mediated CNS inhibition. So again, we'll go over the mechanism. Alcohol mimics GABA at the receptor site. So GABA is the most abundant inhibitory neurotransmitter in the CNS. So alcohol withdrawal causes an increase in CNS activity. Benzodiazepines are titrated until the patient is slightly somnolent and then gradually tapered. Lorazepam is preferred in patients with advanced cirrhosis or alcoholic hepatitis, as chlordiazepoxide or chlordiazepoxide may cause over-titration in these patients. IV fluids, importantly IV thiamine, B1, to prevent Wernicke's. Magnesium and multivitamins, including B12 and folate, electrolyte repletion should also be done. So to go over alcoholic dependence, alcohol abuse becomes dependent when withdrawal symptoms develop or tolerance is noted. So you want to do the CAGE alcohol screening. Over 2 are considered a positive screen. CAGE, cut down, annoyed, guilt, or eye opener. Cut down, have you ever felt the need like you need to cut down on drinking? Annoyed, have people told you that they were annoyed with you when you drink? Guilt, have you ever felt guilty about your drinking? Eye opener, have you ever needed an eye opener to start your day or to reduce jitteriness? For management, supportive psychotherapy, Alcoholics Anonymous, inpatient and residential rehab programs. You can also use disulfiram, which is also called antabuse, which can be a deterrent to alcohol use. The mechanism of disulfiram is inhibiting aldehyde dehydrogenase. This is an enzyme that's needed to metabolize alcohol, so this leads to an increased acetaldehyde when coupled with alcohol intake, leading to an uncomfortable symptoms, which include hypotension, palpitations, flushing, hyperventilation, dizziness. So it really propels you to not want to have alcohol as an intake. It's contraindicated in cardiovascular disease, however, also diabetics, hypothyroid, and epilepsy. For naltrexone as well, this is an opioid antagonist that reduces alcohol cravings and reduces alcohol-induced euphoria. Gabapentin and topiramate. Cocaine intoxication and withdrawal. Cocaine intoxication. The mechanism produces a stimulant effect via the inhibition of reuptake of dopamine, norepi, and epi in the synaptic cleft. Dopamine plays a role in the reward system of the brain, and intoxication leads to a elevated or euphoric mood, psychomotor agitation, or pressured speech. It may progress to nausea, vomiting, and seizures. And for cocaine intoxication, findings will include sympathetic hyperactivity, increased motor activity, tremor, flushing, hyperthermia, cold sweats, pupillary dilation, hypertension or hypotension can be both seen, and tachy or bradycardia. If it's severe intoxication, however, respiratory depression, arrhythmias, hypertension, seizures, repetitive behaviors like picking at skin, agitation, aggression, hallucinations, or paranoia. Deadly complications include MI, stroke, intracranial hemorrhage. And you want to do reassurance with benzodiazepines for mild. Severe or psychosis, you can do an antipsychotic and treat the arrhythmias. Do not place them in restraints, however. They may get agitated and it may lead to rhabdomyolysis. Cardiovascular effects, you want to use benzos. Hyperthermia, cooling blankets. Cocaine withdrawal, characterized by cravings with resultant dysphoria, post-intoxication depression, anhedonia, hypersomnia, increased appetite, and constricted pupils. They may develop nightmares, suicidal ideation as well. It's mainly symptomatic, however, but they may need hospitalization for the psychiatric symptoms. So next will be PCP intoxication. PCP is called phencyclidine, and it's a dissociative, anesthetic, hallucinogenic drug that is an NMDA glutamate receptor antagonist, also called angel dust. PCP is also activating the dopaminergic neurons, and it can cause CNS stimulant or depressive effects. The short onset of action and brief duration of about 1 to 4 hours. They often have impulsivity, fear, homicidality, rage, psychosis, delirium, psychomotor agitation, hallucinations, multi-directional nystagmus as well. In severe cases, may be associated with hyperthermia and seizures. For management, supportive care, airway, breathing, and circulation, placement in a low stimulus environment. Benzos are the first-line agent for chemical sedation if agitated, hyperthermic, or PCP-induced hypertension and seizures. Antipsychotics can be used as well. Marijuana intoxication and withdrawal, binding to the cannabinoid receptors, euphoria, anxiety, disinhibition, intensification of sensory experience, dry or cotton mouth, increased appetite, and motor impairment. Physical exam, conjunctivitis, tachycardia, hypotension, treatment not usually needed, symptomatic management if needed. You could also have cannabis hyperemesis syndrome, chronic severe emesis in chronic users. Managed with the cessation of marijuana use and antiemetics, ondansetron, metoclopramide as well. Next will be grief reaction. Grief reaction is an altered emotional state as a response to a major loss, such as the death of a loved one. Only persistent complex bereavement disorder is considered a mental disorder. 5 stages of grief: denial, anger, bargaining, depression, and acceptance, DABDA. Denial, anger, bargaining, depression, and acceptance. Normal grief usually resolves within 6 months to 1 year. It peaks usually within the first couple months after the loss, and it's usually characterized by intense emotions, appetite, or sleep disturbances. Symptoms may include illusions or hallucinations of the deceased that the patient understands is not real, and patients are usually able to function. Abnormal grief, on the other hand, is severe symptoms over 1 year, or positive suicidal ideation, psychosis, illusions, or hallucinations that the patient perceives are real. Persistent complex bereavement disorder. This is severe grief reactions that persist over a year, or 6 months in children, after the death of the bereaved. And for management, psychotherapy, short course of benzos may be needed. So now we'll go to neuroleptic malignant syndrome again. So this is a rare but potentially deadly complication of antipsychotics, dopamine antagonists, especially the first generation typical antipsychotics. It's most commonly seen in young males early in the treatment. And fever is the most common presenting symptom in altered mental status. Autonomic instability is seen, tachycardia, tachypnea, hyperthermia, fever, blood pressure changes, and incontinence, importantly. And they'll have the classic lead pipe, muscular rigidity, almost universal, tremor, elevated white blood cells, leukocytosis, and CPK, which is from rhabdo. Regular-sized pupils distinguishes it from the mydriasis and serotonin syndrome. And remember, serotonin syndrome, cyproheptadine treatment, as well as benzo. Excessive sweating, diaphoresis here, neuroleptic malignant syndrome, and delirium, altered mental status. And also a decreased DTR in NMS. So the management is prompt discontinuation. The medication, of course, is most important, and supportive care, cool blankets, IV fluids, dopamine agonists, bromocriptine and amantadine, and dantrolene for rigidity and fever. So remember, NMS is BAD, BAD, bromocriptine, amantadine, and dantrolene. So the last topic for this psychiatric section will be narcolepsy. Narcolepsy is a long-term neurological disorder characterized by decreased ability to regulate the sleep-wake cycles. Elements of sleep interfere with wakefulness, and elements of wakefulness interferes with sleep. Typically presents initially in the teens and early 20s, so they could have a number of different manifestations. They may have some chronic daytime sleepiness. They may have cataplexy, which is emotionally triggered transient weakness of the muscles, such as in excitement, laughter, or anger. The weakness often begins in the face with slack and ptosis, and hypotonic face with an open mouth, and often affects the neck and knees. Patients may develop bilateral weakness or paralysis in cataplexy. They may also have hypnagogic hallucinations, which are vivid visual, tactile, and auditory hallucinations as the patient is falling asleep. Or they may have sleep paralysis, complete inability to move for 1 to 2 minutes immediately after waking or before falling asleep. They also may develop other sleep disorders like fragmented sleep, OSA, restless leg syndrome, sleepwalking, and REM sleep behavior disorder. So you want to do a thorough medical history, physical exam, sleep history, and neurologic exam. Workup is usually including polysomnography as well as a multiple sleep latency testing. So for the polysomnography for narcolepsy, it excludes alternatives and or coexisting causes of daytime sleepiness. For narcolepsy, you'll see spontaneous awakenings, mild reduced sleep efficacy, and increased light non-REM sleep. For multiple sleep latency tests, this identifies the sleep onset rapid eye movement and measures the mean sleep latency. The patient is placed in a sleep-induced environment and is instructed to try to fall asleep. On average, healthy patients fall asleep in 10 to 15 minutes. However, in narcolepsy, they often fall asleep in under 8 minutes. The naps usually indicate a sleep onset rapid eye movement. So prior to testing, patients should discontinue antidepressants for 3 weeks. So management is modafinil. Modafinil is the first-line medical management for narcolepsy. It improves control of sleepiness, promotes wakefulness early into the evening. The exact mechanism is unknown, but it's thought to inhibit dopamine reuptake, increasing dopaminergic signaling. Adverse effects: headache, dry mouth, diarrhea, decreased appetite, and nausea. And that's it. So cataplexy, REM. Cataplexy is also REM, suppressing medications, fluoxetine, venlafaxine, and atomoxetine. So overall, narcolepsy, knowing cataplexy, the emotional triggered transient weakness of the muscles, polysomnography with multiple sleep latency study as workup, and management is modafinil as the first-line management. And that completes the psychiatric and behavioral health section of Pance Prep Pearls.